suggestions, it is welcome, so that it can be improved in future and we can correct and make it come in a better way. So those are our efforts. By half an hour, I'll get the link. So I wish all the delegates, please give the feedbacks. So yesterday, our Secretary President came at around 8 p.m. after operation. They are taking the hard work for this conference to be successful in all way. So all the EC, most of the EC members are also there. Tamanash, Roshan Shetty, everybody were there and came. We are going to start it very shortly. I'm just coming up with the scientific lectures. I think Dr. Varghese, can anybody please inform Dr. Varghese to come, because he was taking tea just, yeah. So he can, he will be talking on how to assess a difficult lab coli after entry, say after you put the telescope and, oh, okay.
Next speaker.
Then I think Dr. Roshan Shetty is there. He has enough experience to explain. Should we establish CVS in cirrhotic patients undergoing lab coli? No, no, it's not that. It's not that you have to show video. We can have an exchange of views also, that what should be done. We will, like a panel discussion. If anybody wants to show videos and, I'm telling you. What should I do peroperatively in a GB with suspicion of malignancy but unable to establish CVS? Yes. How to manage GB polyps? Artificial intelligence and the surgeon. That was supposed to be talked by me. I have that. Complications of groin hernia and management. Grossly, it's not in details. Managing. The question, yes. Yes, disaster, yeah, disasters. He is ready, I know. Managing cholecystoenteric fistula. Which procedure to adapt by the beginners, tape or the tap? Yes. Preoperative assessment of a difficult lap coli. And when should an enteroductal bypass be considered during choledocholithiasis? So these are the small topics which we want to talk on. So if you want, I may start with the talk of artificial intelligence and the surgeon.
একটু অডিওটা ছাড়ো আমাকে ওটি বলো।
Check, 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 1, 2, hello. Hello, check, check, সবাই
এটা
পাচ্ছিস?
কোন ওটি? ওটি
Hello,
টু?
hello,
আচ্ছা
hello,
বিমল দাকে একটু জোরে কথা
hello,
বলতে বলো।
সবাই?
হ্যাঁ
Hello, সবাই পাচ্ছিস?
শুনতে পাচ্ছি, হালকা লেভেল বাড়বে। বলছি তোমাদের লেভেলটা হালকা বাড়বে।
Check, hello, hello,
হ্যাঁ ওভারঅল।
hello, check, check. Hello, hello.
ওকে সেকেন্ড মাইক।
বিমল দা এটা কিসে বলছিলে?
বলো।
Hello, hello, check, 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 1, 2, hello. Hello, check, check. Hello, hello, check, check. 1, 2, 3, hello, hello, check, check. Hello, পাচ্ছিস?
পাচ্ছি পাচ্ছি।
প্রথম একটা দিল এই তো সেকেন্ড।
তাহলে এই সেকেন্ডটা হালকা লেভেল কমাও।
হ্যাঁ?
সেকেন্ড মাইকের লেভেলটা হালকা কমাও।
এক নম্বরটাই?
এই মাইকের লেভেল এখনো কমবে, এখনো কমবে।
দেখো বিমল দা বলো।
চালু হয়নি রে।
বিমল দা বলো।
Hello, may I have the PowerPoint of the artificial intelligence and the surgeon audiovisual? अरे तुम दोनों ही जाओ। अरे এই उनको এই ডক্টর বোধরা মাখনদা তো আছেন। হুম May I call upon Professor Hiranmay Bhattacharya, Dr. Professor Sudev Saha and Professor Makhonlal Saha. Okay. Okay. Please, Makhonlal. এই ওইগুলো এআই অ্যান্ড সার্জেন্টটা দিতে বল। আচ্ছা শৈবাল দাও তো প্রিপেয়ার করে এসছে, হি ক্যান অলসো সে আর্টিফিশিয়াল ইন্টেলিজেন্স অ্যান্ড দ্য সার্জন। Yes, AMASI Secretary Dr. Devashish Sharma has arrived. Please, please come. Hey, Roshan, Devashi ko uska talk pata hai? Tape or tap by the beginners? He's there, he's there. তুই বলবি আমি বলবো তারপরে দেবশ্রী এসে গেছে। পেন আমাদের পেন নেই। এই শ্রীকান্তিয়া, এই ডক্টর শ্রীকান্তিয়া Please. I request Dr. Sikantia to be a chairperson with Dr. Makhulal Sah. So, may I? Good morning, our respected audience. So, we are sorry that we are a bit late because of the weather and everybody is late. Somebody have wake up late. So, let us start. This is an inevitable thing, the artificial intelligence, and we should relate it with the surgeon of today. Now, artificial intelligence is the study of algorithms that gives a machine the ability to solve problems, recognize words and visual aspects within images, and make predictions based on its statistical inference. In healthcare, it is able to review large number of patient data, radiological scans, surgical videos, and utilize those informations to detect, classify, and predict. There lies the importance of artificial intelligence. Now, how it helps the surgeon? When a surgeon is performing a minimally invasive surgery with a 3D reconstruction, AI can analyze the operative procedure in real time. The surgeon can be provided crucial decision support through a parallel video display by an already programmed system. Now, the role is the surgical safety. It can map out the surgical approach in a particular patient and guide with information. So, a surgeon can know whether there might be any complications or like that. It has the ability to anticipate the next 15 to 30 seconds of an operative procedure based on reviews of millions of surgical videos of that particular procedure. Say it is CVS. So more the data is incorporated, more informations will be received by the surgeon. And it has been in the literature that in establishing CVS, computer vision is showing promising outcome than the human vision. Now, role in outcome of the patient. In near future, AI may enhance the surgical decision making in perioperative surgical care. It can also bring an integrated information from various data sources like updated surgical recommendations, guidelines, investigation of choice, etc. to improve the patient care and enrich surgical knowledge and the skill of the surgeon. Though it should be an institutional thing that guidelines, everything should come in an institutional way, not in an individual way. That will be a better one. Now, regarding training of the residents nowadays, it has been seen that the AI significantly improves the performance of the residents in performing safe laparoscopic cholecystectomy. Yes, it has come in the literature. AI may act as an expert escort to the residents during performing a procedure. It can help them when they are in the periphery or like that, something where they're alone and very few people to help them when they are in distress. But there are perils of the artificial intelligence. Any new concept has its initial obstacles of acceptance for obvious reasons. Resistance is one of that. Insight thought is necessary to find out ways how to overcome the resistance of change for both the doctors and also for the patient. Another one is the limitations and bias. Mismatch between the software company marketing strategies and the interest of actual purpose of the artificial intelligence is a very important aspect. Another one in nowadays is the accountability. Any complication following a procedure under AI, surgeon, hospital, database creator, software company, who is or shall be held accountable is now still, there is no legal clarity. Is AI going to replace a human surgeon is a big question to many surgeons of the modern era. Dr. Walsh rightly expressed, artificial intelligence is an opportunity to augment the great work we do more than as a threat to what we do. Artificial intelligence should be taken as an enabler rather than a competitor. In all probabilities, artificial intelligence is going to revolutionize the surgical care, and artificial intelligence is being developed for decision support for the surgeons and not to replace them. And one has to understand, at one hand, aging of future healthcare professionals is a great concern in the whole world. According to the 2017 data of the World Population Concepts, by 2050, there shall be double the number of more than 60 years age of doctors. and as of today, and by 2100 it shall be triple. So we need help of doctors when the youngest number of surgeons will come down. In that case, artificial intelligence may have a better role. But on the other hand, the array of technologies may offer brilliant solutions, but it lacks the empathy a doctor shares when the patient is having needs, trust, feelings, and the compassion. So, in modern surgery, in modern era, we should have the mindset to adapt to the changes, and then we should change ourselves to adapt to the newer concept. I think that is the essence of accepting artificial intelligence. Thank you very much.
Thank you, Dr. Bush, for enlightening us about the newer concept of AI. AI is actually already there in healthcare. If you go to the virtual simulators, they're all AI. In virtual simulator, you can practice doing a lab chole. It can bleed, you can hold that. So it is already in practice. So AI is going to come. We cannot say that AI is not going to come, because AI is based basically, as you said, on thousands of pre-existing happenings which are being analyzed. So it will be definitely a tool for us in future. Any comment?
Thank you.
Okay, thank you. So next will be Dr. Debushi Sharma to speak on what to adopt at the beginning, TAPP or TP.
Kalpesh is actually waiting there. Good morning, sir, everybody. Thank you, chairpersons. I think it's an excellent event being happening. Vishwarup, Dr. Abhimanyu, congratulations to both of you. It was far, means I cannot explain actually what I have seen and what I thought when I came here. So, first, these lecture when Vishwarup gave me, I thought this is to be taught to something to PG students and or people who are directly starting their laparoscopic surgery journey. So I've made only 5 slides, a few points in all the slides just to say for the topic, TEP versus TAPP, what to start with. We all know that TEP and TAPP is going on for the last so many years, and all of us are well versed with both TEP and TAPP. But the point is, a person who is starting his laparoscopic surgery journey, which one to start with, and the pros and cons of each of them. Is there any advantage of starting with one or starting with the other? This is what I would like to say. Just these 2 slides, I don't have any videos, this to think the basic difference between TEP and TAPP. TAPP is transabdominal preperitoneal repair and TEP is totally extraperitoneal repair. Where in TAPP, what is done, if you take that red line to be the abdominal wall and the blue line to be the peritoneum, in order to stay extraperitoneal, one has to go inside the peritoneal cavity and then come outside. This is TAPP, transabdominal preperitoneal repair. In the totally extraperitoneal, one stays only extraperitoneal. No need to come. The idea is not to come intraperitoneal. That is the basic difference between the two. Now, considering these two surgeries, we do all our we start our laparoscopic surgeries with lap choles, lap appendix, maybe diagnostic laparoscopy first, followed by lap appendix and laparoscopic cholecystectomy. Then moving on to hernias, which initially were considered advanced procedures. Moving on to it, we are versed with an anatomy of the intraperitoneal anatomy. So the issues of TEP first was the anatomy. Anatomy was something we had to learn. We had to unlearn our original anatomy and then relearn the anatomy. The second point regarding issues with TEP was the space of dissection. As you had shown in that image, the space was small. One had to get to that area, one has to get to that area and do all the dissection in that area. And if there is an inadvertent bleeding or there is a loss of the gas or creation of a pneumoperitoneum, that space further used to decrease. Initially, when TEPs were described, they were described with 3 ports in a same line. But subsequently, people have modified it. Yesterday, Dr. Varghese sir also showed us a good triangulation with TEP, and the Palanivellu TEP also has a very good triangulation technique of putting the ports. So these were initial issues which people do have overcome. But for a person to start with, these other, like bleeding and air leaks, can be issues which decreases the space, the extraperitoneal space. So in order to avoid these, people have started with TAPP also. Now, there will be many who have never done a TAPP and started his career with a TEP and still doing TEPs. There have been many who have started with TAPP and gone to TEP. There are many who have started with TAPP and have remained with TAPP only. We have a surgeon in northern India, he has done more than 10,000 TAPPs but never has done a TEP. So it is very difficult to say exactly which one is better than the other. There has been numerous publications. We also published our literature in around 2015 comparing TEP and TAPP in bilateral hernias. We hardly could find any difference between the two. The one which you are used to, the surgeon who was used to TEP used to take lesser time in TEPs. The one who was used to doing TAPP was taking lesser time in TAPP. The point here is that the TAPP technically, as you go intraperitoneal, create the flap and again have to suture the flap or retack the flap, the time taken should be ideally higher. TEP time should be less, but the person who is well versed with TAPP can do a TAPP at a lesser time compared to a TEP. So knowledge of anatomy is one thing, unlearning it and relearning it, and seeing and assisting cases. Whatever case is being done, whatever case one has seen is more important. Nowadays with cadaver workshops coming up, knowing a cadaver, getting into a cadaveric workshop, seeing the surgery there can help you when you started. Now, when you started, this is more important than whether you do a TEP or a TAPP. You should try to choose your case, which should ideally be, mostly we are right-handed people, it should be a right-sided because then the right working with the right side, it's easier for you to operate. These hernias should be uncomplicated. They should be primary hernia, not recurrent hernias. Small, direct hernia. This is the hernia which one should choose. And avoid obese patient. This is a point which is not written here. These are the points one should put into consideration while choosing the patient. Now, beyond TEP and TAPP, the argument is, can we do an ETAP? The ETAP, which is also called the extended view TEP or the enhanced view TEP, some people call it an exciting TEPs also. The point, what happens in this ETAP is the ports are further away from the hernia. We avoid that two instruments touching each other. Dissection is no doubt more in this because we create a huge space. And because we create a huge space, larger hernias can be operated. Hernias which are obstructed also can be operated. And this is a procedure which can maintain the extraperitoneal advantages of the repair, the TEP advantages of the repair. And it can be easy for the beginners because of the avoiding of the space concern. Now, the question which is to be answered is that, are the ETAPs decreasing the TAPPs? This is not in the purview of my lecture, so I'll not go beyond TAPP. If you look at the incidence today in the last 3 years or 2 to 3 years, the incidence of TAPP, a surgeon who is doing both TAPP and TEP, his incidence of doing TAPP is decreasing day by day. Concluding, ladies and gentlemen, for the day, knowledge of anatomy is one important thing. The cases which one has seen or assisted is very important. Whatever the procedure one has seen, one tends to follow it. When you start, you can do that. Cadaveric anatomy and cadaveric courses are the rule of the day, and case selection is absolutely mandatory. Thank you very much.
Thank you, Deboshi, for that brief talk on TTEP and TEP and TAP. So
probably the message didn't went. You can start either of them. What a person will start, what the person has seen, what the person has done, his seniors has seen, he has assisted, he has done. That is to be started. Number one, you have to. Case selection is more important. Case selecting the right case to start with. TAPP and TEP both, first thing is that the literature which says that they have got absolutely almost equal results. There are few things. Inferior epigastric artery injuries are slightly more in TEP, slightly more. That's not significant. But the significant thing is that holding that inferior epigastric artery during a TEP in that closed space is slightly difficult than TAPP. That part is important. Incidence is almost very slightly similar. Then bowel injury. Bowel injury should not happen in TEP. Should not happen. But it is not that it doesn't happen. Bowel injury is reported in TEPs also.
More in TAPP than.
It can be more in TAPP, but TEP doesn't preclude any bowel injury. So technically, if you look at it, statistically, there is no difference. My topic is what to start with. You can start with either of the procedure, what you are used to. I've said 3 conditions, 3 type of surgeons who started with TAPP, moved on to TEP. You have surgeons who have started with TEP and remained in TEP. You have surgeons who have started with TAPP and kept on going with TAPP. So both the procedures are good enough. Now, in 2024, the argument is that whether that ETEP, which doesn't violate the peritoneal cavity, TEP doesn't violate the peritoneal cavity. That is the argument given by everybody. ETEP also doesn't violate the. Is ETEP replacing TAPP? That is the argument today.
Okay. Yeah.
Right? It's for beginners also. You can create more space. You can have more space and.
Okay. Point taken. Thanks, Deboshi.
I
move
think
on.
One more thing regarding this TAP and TAP. For the juniors, it also depends upon their mentors.
That is what I said. What he has seen. What he has seen.
Trained with that.
Thank you.
But generally, I think for beginners, TAP would be better because they have better working space there.
Yeah. No.
Yes,
No, the
correct.
initial.
Also, to learn suturing also, it's better. And like one point where you said, if you're a right-handed person, start with the right side. I think if you're a right-handed and if you want to start TEP, then better look for left-sided hernias, which is more of bupinoceal, smaller direct hernias. Because the initial dissection is in the midline, so your right-hand working port will not puncture into the peritoneum. So you have better space there. Otherwise, what happens if you take a right-sided hernia, the right working port, there is a tendency that you enter the peritoneum and you lose space.
I'll explain to that. The surgeon does a diagnostic laparoscopy first, then does an appendicectomy and a lap chole, second and third. This is the routine. Then he moves on to hernia. All these surgeries, the surgeon does it from the right side. A diagnostic laparoscopy at the head end or left side of the patient with the right hand actively. The cholecystectomy is also on the left side of the patient. Appendicectomy is also on the left. Invariably, some people describe it from standing between the legs. So when you move on to a hernia, what do? You instead of the scope towards the upper abdomen, you put the scope towards the lower abdomen. That when we started it, every time we used to do a cholecystectomy, we used to put the scope towards the lower abdomen, see those vessels, see the anatomy, put the patient little down, bring the bowel down, see that if when we do a hernia, we will cut here, visualize it and visualize it ourselves, and then go back and do the cholecystectomy and come out. This is what we used to do in our time. So what is that? That is using it. I'm standing on the left side of the patient using my right hand. So when you operate a right-sided hernia, right-sided direct hernia, you just need to shift from the upper to the lower side. When you do a left-sided hernia, you have to stand again on the opposite side. That is that again becomes a new added anatomy. That is why a right-sided, and the right hand is working. Right hand is working. On the left side, when you stand on the right of the patient, you are a right-handed person, the right hand doesn't have too much of function. The left hand has got more of function because creating the bowel space, holding the peritoneum, and all these things. So if you have a right-sided hernia, I think that gives a... Sir?
You have to face the first patient. That comes to
that is very true. Selecting the first patient is very, very
important. You should
not
take a very complicated large hernias.
Uncomplicated small direct hernias.
Yeah,
No, in a non-obese person, not a recurrent primary hernias.
Points taken, Deboshi. Thanks for the
Next
good discussion.
Speaker will be Dr. Basu, who will speak on a very common entity we come across in our daily practice, patient coming with a ultrasound report of gallbladder polyp. So how to decide when to proceed for surgery or keep on watching. Dr. Basu, please.
Start कर फर्स्ट नहीं लास्ट है क्या दिखा है नहीं फर्स्ट तो क्या करते हैं देखो उसको चले पहले चले हाँ ठीक okay so very good morning and welcome to you all. So the gallbladder polyp often we encounter from the referral of the medical people that there is a tumor in your gallbladder, so go and get operated. So gallbladder polyps are benign lesions, as you know, originating from the mucosa, but cases with a diameter more than 1 centimeter and adenomatous features are of clinical importance due to the possibility of developing cancer. In the literature, the rate of cancer development of polyp has been reported to 0 to 27%. So there is a wide range. The likelihood of diagnostic confusion increases the clinical significance of polypoid lesions of the gallbladder, because the polypoid appearance of gallbladder cancer also like that. So the fact that the algorithms for diagnosis and treatment have not been developed yet, and it can cause the stress on the doctor and anxiety in the patients. So these are all the polypoid lesions of the gallbladder, but we will only focus on the cholesterol polyps, adenomatous polyps, and adenomyomatosis. So this is the most confusing one, the cholesterol polyps and cholesterolosis. So now the cholesterol polyps are the most common clinically encountered lesions and have no neoplastic features. It is accepted that the cholesterol polyps are formed as a result of phagocytosis of the cholesterol esters and other lipids, that means triglycerides and all, by the macrophages found in the lamina propria, and coverage of the columnar epithelium by cholesterol containing foamy histiocytes. So cholesterol polyps attach to the wall by a stalk, like a ball on the wall. And you know the cholesterolosis, that is broad lesions. The mucosa gains a carpet pattern of yellow-green colored papillary structures with a diameter less than 1 millimeter. This appearance is also called the strawberry gallbladder. In our MBBS, always we get a short note in strawberry gallbladder. So interestingly, there is no relation between the cholesterolosis and gallstone formation. And secondly, there is no correlation between the cholesterol polyps and serum cholesterol levels. So you cannot say that, yes, your abnormal lipid profile may cause the cholesterol polyps. That's wrong. So we have all seen this strawberry type of gallbladder. So now these two are clear nowadays. Still there is cholesterol polyp, what is the size, what is the thing like that, but when you got an adenoma and adenomatous polyp, the treatment nowadays is clearly guideline. So neoplastic lesions mainly include the adenomas and mesenchymal tumors. So there are true polyps. Although the incidence of adenomatous polyp is not completely known, it accounts for the 4% of the polypoid lesion. Neoplastic lesions tend to be single, while the non-neoplastic lesions tend to be multiple. So neoplastic types of benign polyps have the potential of malignancy. So the risk of cancer is high when the diameter is greater than 1 centimeter. Approximately 1/4 of the adenomas become the cancerous, and the risk of developing cancer in adenomatous polyps greater than 1 centimeter is reported to be 25 to 75%, 25 to 75. So this is the typical sagittal section of gallbladder specimen showing the true neoplastic polyps of the neck. See the adenomatous polyps of the gallbladder and the adenomyoma or the adenomyomatosis. Adenomyoma are the hyperplastic non-neoplastic lesions developed from the gallbladder wall, and adenomyomas are the most common benign polypoid lesion after cholesterol polyps. They generally considered to develop during the cholecystitis episodes as a result of mucosal hyperplasia or thickening of the muscular tissue, and they are usually located in the fundus. They may be developed in generalized adenomyomatosis, annular, segmentary, or localized form. Previously, we all know, and all the literatures and all the textbooks, the adenomyomatosis is a benign lesion. Still, there are many books, they are written, the adenomyomatosis is a benign lesion. So, we also treated benign lesion and just observed the patients. But NCCN guidelines accept that the adenomyomatosis gallbladder has a potential risk of developing gallbladder cancer. So, nowadays, our policy is all adenomyomatosis should be operated. Typical adenomyomatosis is the focal wall thickening. So radiology, again, if there is no definite radiology, we can differentiate between the adenomatous polyp, adenoma, or cancer. But there are newer things like endo-US or contrast-enhanced USG to differentiate between the features. So now the proposed management of algorithm from GBP, all you know that if it is symptomatic, then we can go for the cholecystectomy. And when there is asymptomatic, if the size is more than 10 millimeter, that is 1 centimeter, age more than 50 years, gallstone with gallstone, adenoma, and sessile polyps, this is controversial again, how to operate or not. And size less than 10 millimeter, these are the things which we are, there is lots of difference between the opinion between the different countries and their association guidelines. But straightforward 1 centimeter or 10 millimeter or the increasing size in serial USG is the indication for the cholesterol polyps. Otherwise adenoma and adenomyoma is straightway cholecystectomy. 1 centimeter in all surgical textbook, but recent European gastroenterology guidelines, they said that no, 8 millimeters should be the borderline. Thank you so much.
Thank you, Basu. One question.
Yes.
Is there any possibility for sending frozen? Suppose you have clinically or intraoperatively you find
yes.
the gallbladder. Is
yes,
there a possibility?
Yes. But
that?
for the polyp, there is no routine suggestion for frozen section. But yes, if is any gallbladder lesion which is suspicious, you can go ahead. Total intact cholecystectomy and then frozen section. No partial one. Thank you.
Thank you.
The problem with decision making is radiological finding.
Yes.
Most of the patient comes with a ultrasound report saying that there is cholesterol, somebody saying focal adenomyosis. So basically it's difficult to make out from an ultrasound report is a really adenomyomatosis or a cholesterol polyp.
No, Dr. Shah, adenomyomatosis is a typical radiological feature of comet tail appearance. So main problem is the adenoma of the gallbladder. This adenoma is benign or malignant adenoma. That is the main thing. But adenoma is less in number, about 4% or 5%, the whole thing.
Thank you.
Thank you. Next speaker is? Yes.
Dr. Varghese sir, our president, AMASI. Dr. Varghese will be talking how to assess difficulty in lab coli.
Good morning to all. First, let me start with congratulating Dr. Visru Bose and team for a very great conference and workshop that is going on here for the yesterday and today. And I actually came to know about this topic quite late, so only just a few slides. Anyhow, we'll discuss the issue, please. The gallbladder, usually the difficulty can be assessed before itself, before the surgery, as we all know that by the clinical presentation and also by the ultrasound imaging. Usually we are able to make it out whether it is a difficult one or not. But the discussion is on how to make it out. What are the points of to say that we are dealing with a difficult gallbladder. I think the slides are not coming. One is actually depending whether the patient has undergone a previous surgery or not. If the patient has undergone a previous surgery, there will be scars and you can expect adhesions intra-abdominally. And if the surgery it's related in the right upper quadrant, the scar is in the upper quadrant or in the upper midline, then that is then there can be adhesions in the area where you want to work. So we need to release these adhesions before we have to reach to the gallbladder. So that is one issue. It's coming. I think I'll continue with my talk. The second part is or can you copy that pen drive and then?
Varghese sir, what is your take on there are different classifications, Nazar's classification to help difficulty in gallbladder?
Yeah, that is the second one is the point what I would like to make is that because of the gallbladder, the pathology in the gallbladder, then there can be difficulty. Like if you, because of acute one of the issues that acute cholecystitis, there can be adhesions around the gallbladder, and the gallbladder may be completely, it might be not be freely visible or freely lying. So there will be, the adhesions around the gallbladder. It can be flimsy or it can be sometimes dense adhesions. So we need to release these adhesions before we have to get a full view of the gallbladder up to the callous triangle. Is it coming? I'll continue, I think I'll just a few slides only, I'll continue with that. Then another issue is that the thick-walled gallbladder, it is usually associated with acute cholecystitis and the distended gallbladder. If the gallbladder is grossly distended and if it is thin-walled, then also there is a problem. Because when you put usually that we have to grasp the gallbladder at the fundus for the retraction. And usually an Alice forceps is used for that, a tooth forceps. When you grasp it, actually it can rupture and there can be bile leak. So in this situation, you may have to decompress the gallbladder before and then you have to carry on with the surgery. Other issue that when the gallbladder is grossly thickened also, then the thickness is so much, then you are not able to get a grip on the gallbladder with your forceps. In this situation also, the decompression of the gallbladder is required and to carry out the surgery. And third situation, like the gallbladder is not uniformly thick-walled, etc., or there are features of malignancy to be suspected. Those situations that you need to deal with the surgery in a different way, which I am not going into the details. So, because of the thickness and the distension of the gallbladder, one can come across the difficulty during the laparoscopic cholecystectomy. The third area that you may come across difficulty is at the callous triangle. Now, sometimes there can be adhesions towards the fundus, but then if it is released, then when it comes to callous triangle, it may be a easy dissection there, and you are able to properly demonstrate a critical view of safety. But then, if there is a frozen callous triangle, and if there are dense adhesions, then this can be difficult, and we have to go for a subtotal cholecystectomy. And another situation like a large impacted stone in the in the callous triangle. Here also it is there is a difficulty because of the hard stone sitting at the neck of the gallbladder. You are not able to do a proper dissection with as easy like in a usual gallbladder. So here there are methods to get around it. Probably you can go like a little above that stone and then dislodge the stone and then carry out your dissection at the callous triangle. Then another area that the difficulty we may come across is sometimes the gallbladder is so contracted and it is really small and you are unable to make out what is the gallbladder and where is the callous triangle and situations like that. In this situation, I think that what will be helpful is that always stay away from the bile duct, and your dissection should be even if I think that even if you open the gallbladder, I think what usually my method of doing in this situation is to open the gallbladder somewhere where I know that it is really the gallbladder. I am sure 100% it is going to be the gallbladder. And then assess from the inside, where the proximally towards the bile duct, how much the gallbladder is extending. Then you will be surprised that actually gallbladder may be sometimes so small. Actually, if you had actually gone outside dissection and then taken out, sometimes you may be causing an injury to the bile duct. So this is another situation. And another issue that is come across is that depending upon the type of the liver, that is sometimes the liver is cirrhotic, and in this situation also the surgery can be difficult. So here depending upon that, even the gallbladder that type 1, type 2, type 3 cholecystectomy has been described, like you can leave the gallbladder bed to the liver. If there is a dissection and the gallbladder bed found to be very difficult or bloody, and the mucosa can be cauterized, or it can be mucosa alone can be taken out. The second one is type 2, where the subtotal cholecystectomy is a solution, and the type 3 was subtotal with the leaving behind the posterior wall on the liver. So I think this is a few issues I am just talking about. I think the time of this was given 5 minutes only. Thank you very much.
Thank you, sir. Thank you for your words of wisdom. And there was a difficulty in the audiovisual.
Yeah, sorry for that. Slides could not be demonstrated.
Any questions from the audience? We'll move on with the next talk from
Thank you
Dr.
very much.
Tamonas Da.
So Dr. Tamannash will be speaking on complications in hernia surgery. So you should be knowing about the complications and then to
Showman,
manage
connect.
these complications.
Huh? Done? Good. Good morning, everybody. I feel it's very homely environment. It's not like other conferences. We should interact. That is more vibrant. So it's a 5-minute talk. So I try to stick to the time because Bishwarup is very, give a very strong ruling that we should not cross any time. But complication is our part of life. In every sphere of our life, there is some complications. Even on the day when we are traveling, there is a fog and our flight delayed, and some of the people's flight cancelled. These are a small part of complication in our day-to-day life. And surgeon's life, we the surgeons live in a world of uncertainty. In spite of our all efforts, good efforts, we don't know what will exactly happen. But definitely, we must know the science behind of complications and how we can avoid most of the complications. Same like any surgery, the complications can happen. Mostly I concentrate on the power operative complications. It can be from the access and can happen at the time of surgery. I will not concentrate on access complications because these are common for any laparoscopic surgery. So I will not talk in hernia complications, that one. So I straight away come to the complications of hernia surgery complications. So in hernia surgery complications, major complications is vascular injury, particularly laparoscopic hernia surgery is a very dreadful complications can happen due to vascular injury, which may never happen in open surgery in Liechtenstein repair. So this is one of the major issue in laparoscopic hernia repair. And vas injury and other injury all can happen in open surgery and laparoscopic as well. But here, if we concentrate, this is one inferior epigastric injury. This is one very, when we dissecting in the, taking out the, our sac, we're dissecting, with the small fibers we cut and we ultimately cut the inferior epigastric artery. To manage it, we cannot apply any electrosurgery here because it's very close to the origin of the vessels, from the major vessels. And that is very difficult to manage, so we have to put one more trocar, one more access. We hold with that forceps and we can suture it. That's the one option. Even we cannot apply the clips in this area because we have not dissected at all. So there is a bleeding, so we have to put a suture. It can happen in sometimes like this, inferior epigastric artery, same way. When we are dissecting in, there is a possibility of injury in this. And that can be managed because here it's already in a laparoscopy, it's in the roof, it's not in the root. So some distance from the origin of the vessels. Here we can apply the energy source and we can control the bleeding. Not like the previous one where the inferior epigastric artery injured at the root, where we have to put the suture. Here we can apply because in the far away from the root. So we can manage it by energy sources. This is one of the complications happened because of the judgment failure or because of the selection of the patients. These patients have a recurrent hernias, and these recurrent hernia earlier was right side the rib stopper repair. There is a stopper repair. This means there is already a pre-peritoneal mace is placed, and there is a lot of adhesions. Somehow because of sometimes we thought that we can do anything, and that is the attitude which helps the surgeon to take up this challenge to dissect the mace from the vessels and others, and it's get injured. And when we ultimately there is a injury to the external iliac vein, and that was basically by compression we have managed, but ultimately we have to open it and we have to put a 5-protein sutures, and they will manage. And in meantime, we have asked for a vascular surgeon to take care. And when we introspect, it happens because of that mace itself was pulled out the anatomy, and there is a change of anatomy. It was not a normal anatomy. That's why the dictum is, if there is a mace placed anteriorly, we should go for posterior repair, like laparoscopic repair. Liechtenstein repair recurrence, go for laparoscopic repair.
Laparoscopic repair recurrence, go for anterior repair, lichen stent repair. That's the dictum. We should follow that dictum. And if we don't follow that, this kind of disaster can happen. We know this is the area of corona mortis where a lot of obturator vessels, aberrant vessels which are put together. This area is very, when we dissect in the pubic arch, particularly in the lateral side, we must be very careful in this area. Otherwise, there is a possibility of injury and very difficult to manage this vascular injury in that area. Possibility of bladder injury is there in inguinal hernia repair because particularly in TAPP, if we cross the medial umbilical ligament, at any point of time, between the two medial umbilical ligament, the bladder lies, we should not cross that Lakshman Rekha between the two medial umbilical ligament, the possibility of bladder injury. Sometimes bladder can be in the content of the hernias. So you must be very careful when you reduce the sac, particularly in laparoscopy, either TAPP or TAP, we should not injure the bladder. Vast difference can be injured, and most of the time I have seen surgeons ignores it. And particularly the moment there is a vast difference injury, surgeon look to the board, what's the age of the patient. But honestly, I am telling you, it's, we may feel complacent, the patient is very old and he will not talk, and it is better not to disclose that you have injured the vas. Rather, even if a 75 years old, I have my personal experience, there's a vast difference, and by, to be more honest, to say that there is a vast injury, afterwards he became very angry that why it happens. Even he is a 75 years old gentleman. So they will never take it very lightly that he is a very old fellow, what is the necessity of the vas. Be very careful about it. So most of the time we just ignore or we unnotice that there is a vast difference injury. And there can be, happens to be hematoma if we, because a lot of, particularly the patients on a anticoagulant or the patients have some medications, particularly old people, and if we dissect it, sometimes if required we can put a drain rather than we keep areas where we cannot manage it. I just take another 1 minute. There is a possibility of infections. Hernia is one of the procedures where we should be very careful for sterilizations. Because we are putting a foreign body, we must be very careful about sterilizations. So there is a possibility of mesh infections. Patient come up with a real bad situation with sinus and others. We must be very careful about the sterility of the patients. And one of those, I just show one small video clips where there is a possibility of major vascular injury which can happen. This is basically the anatomy, identification of anatomy. Somehow this video is not running. I am not skipping this video. Ultimately, for any injury, these are the situations where the only person is happy is the lawyer. And the rest, all the people will be unhappy. The patients, relatives, hospital authority, everybody is unhappy. Everybody is in tension. Only the lawyer can be happy if there is a complications. So friends, complications is a part of our life. We must understand how it's always better to learn the complications in in my own life, learn from the others complications, how he had done it, how we can avoid. Thank you very much, sir.
Thank you, Tamanatha.
Thank you.
Wonderful videos. So important is take home message, record and document and communicate appropriately. Next, Dr. Kalpesh Jani sir will be talking on choledocholithiasis, when to consider choledochoenterostomy.
Morning, everybody. So basically my talk was what are the indications for enterodocal bypass during laparoscopic CBD exploration. Yeah. So when you do a lap CBD exploration, there are two ways to go about it. One is of course the transcystic approach, where you have a very small single stone which is smaller in size than the cystic duct diameter. In those cases, you don't actually obviously are not going to need a choledochal enteral anastomosis. You're just going to clip the cystic duct proximally towards the from your incision in the cystic duct, and then that's it. You finish your lap chole, and then you're out. But more often than not, we rarely do this approach, transcystic approach, because most of the time our indications are for much larger stones and complicated stones. So we usually go for this translocal approach, where you go through incision, vertical incision placed on the CBD itself. And there you have 4 options of how to deal with this. And there are different indications for when you will be doing these 4 options. So if you're going to do ADAPT lap CBD exploration, you should know all the 4 options. One is, of course, primary closure of the CBD. Then to do a T-tube drainage, laparoscopic T-tube drainage, laparoscopic prograde stenting, and then closure. And finally, enterodocal bypass. In enterodocal bypass, there are 2 ways. You do a choledochojejunostomy, or you can do a choledochoduodenostomy. So there are basically 5 things that you should know. So enterodocal bypass, compared to open lap enterodocal bypass, is been shown that it is definitely advantageous. So there's all the advantages of minimal access surgery are there in lap as compared to open. So there's not much point talking about this. The indications of enterodocal bypass, these were summarized very nicely by one of the papers from our own colleague Senthil Nathan, and there were many other papers also, but he has summarized this in a review article, that one, there's failure of clearing the CBD stone because of obstruction, and this is one of the commonest reasons, that there is a distal stricture. A stone has got impacted in the distal CBD. Even after the stone is dislodged, there is a strong stricture, so you're worried that the stricture is going to cause obstruction and problems later on, even if you just remove the stones. So in those cases, it's better to provide a alternate route for the bile. There is a very large impacted stone or a very large stone, and there is a huge amount of sludge that is there. So you are worried that the sludge will be there. You are not able to clear out all the sludge. Some sludge can then later on, if it's not provided a alternate route, can go into the cause recurrent pancreatitis. There are multiple small stones. The whole thing is jammed with stones. Patient has a primary hepatic stone, intrahepatic stones. That is, the patient has already had a cholecystectomy more than 2 years prior to the CBD stones being detected. So those are considered as primary intrahepatic stones development. It's a rare condition, but it does happen. And in this condition, what happens is that the patient will keep on developing this primary intrahepatic stones. There are different causes for this. We won't go into that. And for that, you have to provide a much larger opening for the stones to pass through. Recurrent multiple stones. And finally, especially nowadays, we see that when you suspect that post-op, if there is any issue or any access is required, ERCP is going to be difficult, because there is an altered anatomy because of a prior surgery. Like a patient has undergone a Roux-en-Y gastric bypass for obesity, and we know that when weight loss occurs, patients are likely to develop gallstones and can have complications related to gallstones. So in those cases, it's always wiser to consider to set up an alternate, easier route for the bile to flow through. So as we talked about these 2 types of enterodocal bypasses, what to choose, which one to choose, choledochoduodenostomy or hepaticojejunostomy, both have pros and cons. Choledochoduodenostomy, the concerns are there with choledochoduodenostomy as compared to hepaticojejunostomy is that there is a higher risk documented of ascending cholangitis occurring. There is something called the sump syndrome. So where you do your anastomosis between the CBD and the duct, the distal part of the CBD that remains, especially if it is strictured lower down, that will keep on having some stagnant bile and infection and all that. So that is known as the sump syndrome. Patient can have alkaline reflux gastritis, or the duodenal contents can go into the stomach because there is a lot of now bile coming into the first part of the duodenum. It is associated with a higher anastomotic stricture rates, especially if not done very well. So you have to be very sure about your technique. And recurrent anastomotic strictures again are more common with the choledochoduodenostomy as compared to a hepaticojejunostomy, but those may be technical issues. Advantage is, of course, it is easier to access if you want to do any subsequently assess the biliary tree because the opening is there right in the first part of the duodenum. It is more suitable with patients who have already undergone previous surgery for some reason, because in a Roux-en-Y hepaticojejunostomy, the mesentery may be shortened, there may be adhesions, you may not be able to take the jejunum right up to the hilum, so that's going to be this side. And of course, technically, Roux-en-Y hepaticojejunostomy takes a longer time because there are 2 anastomosis. You have to do a jejunostomy as well as hepaticojejunostomy. We'll skip the videos. no need for the technical videos, I think, but this is, thank you for the attention.
Thank you, sir. Any clarification questions from the audience?
Do you take decision based on the duct diameter to do a bypass?
So the indication for a lab CBD exploration, that lab CBD exploration basically you can only do when the CBD size is at least 8 millimeter, or I usually prefer at least 10 millimeter and larger CBDs for a lab CBD exploration.
The thing is that we usually do, as per indication in Bloomgart, that all primary CBD stones we try to do a enteric bypass. So when the optimal 1.5 centimeter is not available for choledochoduodenostomy, which is prerequisite, we choose to do the choledochoduodenostomy. That is not an issue of diameter, but yes, in primary CBD stone, every case we attempt it because it is indicated. And primary hepatic stone is always. That is the hepaticogenestomy with the access loop.
And again, when you have a stricture load up, so many times what happens, there is associated CBD. So one of the commonest indication of doing a enterodocal bypass is stone associated with a stricture, because that stricture is always going to cause recurrent problems.
And choledochoduodenostomy, another point is that definitely there is two anastomosis is a thing, but Ru and Y.
Yeah.
But the thing is that as the jejunum is more vascular and the biliary enteric system is not entered, that means that the reflux ascending cholangitis, as he rightly mentioned. So there are many school of surgeons, they thought the primary operation should be in all cases choledochoduodenostomy, not the choledochoduodenostomy.
So in fact, there is one school of thought that believes that when you have the GI organisms in duodenum going into this, it increases the risk of cholangiocarcinoma.
Yes, cholangiocarcinoma
so
also, yes.
They say that it should not be done, but that's not proven yet.
Like
so
our surgical gastroenterology department in our Sukanto has a
some
lot of publications.
They're quite fanatic about it, that it should never be done, so that's the thing.
Dr. Vimandu, I just missed one word probably. Did you say that any undilated system, if you happen to explore the CBD, you do a choledochoenterostomy?
No.
Primary CBD stone only. Primary CBD stone. That
primary
means
CBD stone in an undilated system.
Yes.
You will do a choledochoenterostomy.
It's
that is
unlikely. Now, if you have a primary CBD stone, it's likely that CBD system will get dilated.
At least 10 millimeter all.
Primary CBD stone without duct dilation is very unusual.
But I mean,
primary small stones with 8 mm, 9 mm ducts are seen, but
no. What does a primary CBD stone mean? When there is no stone in the gallbladder?
No.
So
No. The
or after cholecystectomy, right?
Criteria is that when there is no gallbladder or gallbladder stump for last 2 years.
Yes,
2 years. That is
that's what I
Sharia
mentioned. I
criteria.
mentioned.
small putty
And
stones. soft
then
stones,
the theory is that these stones are formed in the
intrahepatic stones. So
intrahepatic,
basically,
so
these are
they can
intrahepatic stones which are
so
migrated
if you
down.
don't go for the bypass,
Yes,
again it will happen.
They will happen, yeah.
But
That
you
I already
mean to say
mentioned in
that
the
those
indication.
primary post-cholecystectomy, 2 years of multiple
So
stones
basically,
are
primary
they
intrahepatic
do an
stones.
enterostomy.
Intrahepatic
Not
stones.
in a normal cholecystectomy.
No, in those cases, we have other options. No? We have a primary closure. I didn't talk about the indication for the other options. Primary closure, prograde stenting, all of them have separate indications. T-tube drainage. So those options are there.
Thank you. I think Dr. Roshan has a presentation. No?
Are we done?
Thank you.
Live workshop?
So now we will shift to the live surgeries. They are already ready with the cases. So may I ask the audiovisual to connect to the North Bengal
two
Medical
cases
College?
are on the table. One is CBD and one is
gallstone,
bilateral inguinal hernia, and also the piles is also ready.
Thanks, the chairpersons, Dr. Srikantia and Dr. Mahalal sir. Yes. Can we have the audio over there, the surgeon, if he is there? Connect to OT. Dr. Rudra, please. Dr. Rudradeep, please come. Please, I got it. I got it.
Knife.
Hello? Hello? Dr. Jayanto?
Yeah.
Are we audible?
Yeah, I can hear you.
Okay. So I am handing over to Dr. Abhimanyu Basu, the moderator, and he will call the panelist.
Yeah, morning. Morning to you all.
Panelist.
To all the panelists. Scope. Ureteroscope.
No, এটা না এটা।
Yeah, can I get the knife?
এটা কালকেরটা হ্যাঁ। যেটাতে সিবিডি ইনজুরি ডিসকাস হবে। কি হচ্ছে এটা? কাগজটা নিয়ে তো বিরক্ত করলো আমাকে, আমি তো কাগজ দেখতে পড়তে কমফোর্টেবল থাকি না।
So, Dr. Bijay Kumar Panda. Dr. Panda is here. Dr. Sudev Saha. Dr. Sudev Saha is there. Dr. Hiranmoy, please. Dr. Ankita Singh.
Off करके रखिए.
Dr. Rudradeep Banerjee. Dr. Ratnojit Das. Nobody is there. Patania sir, can you be in the chair? Because we will not discuss this CBD exploration because it is discussed yesterday whole. Now today we will rather discuss on the CBD injury that is no relation with the CBD exploration. It's related only gallbladder operation, but we have to discuss CBD injury, that's all. Anybody voluntarily want to join in CBD injury? Sanjeeva Chaudhary sir. Because everyone does it, everyone sees it, but very rarely you repair it, I know.
নেক্সট প্যানেলটা দেখে রাখো যারা ইয়েটা ওইটা দেখো যেটা ইয়ে কর প্রকাশ করে।
So Jayanto, can you hear me?
ওদের একটা
Jayanto, can you hear me? Can you hear me, Jayanto? He can't.
আচ্ছা ওইখানে গিয়ে একটা সাইড স্ক্রিনে গিয়ে আমাদের ছবি অফ করে ওখানে ওই প্যানেলটা দিতে বল। একটা লেখা আছে এটা দিতে বল, ছবি বাদ দিয়ে দিতে বল। সাইড স্ক্রিনে ছবি বন্ধ করে দাও আমাদের ছবি দিয়ে ওই ফাইলটা কিন্তু যদি কালিম্পং করে একটা সাইড স্ক্রিন প্রোগ্রামে দেখো আমার নামে দেওয়া আছে। ওটা কোন ইয়েতে ওইটাতে ওই ল্যাপটপে সেটাকে সাইডে প্রজেক্ট করিয়ে দাও। আর ওটিতে বলো যে সার্জেন্ট শুনতে পাচ্ছে না। বলে দিচ্ছি আমি বলে দিচ্ছি।
So, very good morning. Sir, all the moderators. Oh, Rajdeep Singh. Okay. So this is the CBD injury panel. Though we are showing the CBD exploration by Jayant Kumar Das, in between his steps and all, we'll discuss the CBD injury, right? And the next operation, our bilateral TEP, the moderator will be Dr. Rajdeep Singh. And what the panel, Rajdeep will call when these patients are. So Jayanto, can you hear me? Jayanto, can you hear me?
Hello.
Huh, Jayanto?
Hello?
Yes.
Yeah,
Yes,
morning.
yes. See, Jayanto, the program
I
is.
can hear you. The history will be given to of the
Yes,
patient
yes,
of the
yes.
the history. You just
Yes, yes.
Hello. 65 years old female presents with us with right upper quadrant pain for last 6 months, associated with nausea and vomiting and fever. Her last acute attack was 1 month back. There is no history of jaundice. Patient is known case of hypertension and hypothyroidism. Patient is on medication for that. And her recent MRCP report on 23rd January 2024 reveals that 17 millimeter calculi at GB neck, and her CBD diameter is 13 millimeter and 10 millimeter calculi at distal part. Now patient is admitted for laparoscopic CBD exploration.
Hello. Guess on, please. Make it 12. Pressure 12. Yeah. On this. Yeah. No oxygen and betadine will be.
Hello. Dr. Jayanto,
Hello.
good morning. I'm Dr. Jugindra from
Morning,
the
Jugindra,
auditorium.
sir.
Yeah. Yeah, please update us. What is the position, situation?
Betadine, please, little bit. Betadine. Betadine.
Yeah, Dr. Jayanto, what is the plan?
This is a case of CBD stone. According to MRCP also there, I think it is 11 mm CBD with few 13 mm with few stones. So I'm going for a lab chole as well as CBD exploration using a ureteroscope. 5
Right.
mm.
Can someone show us the MRCP picture on the view box?
Yes, sir.
Can somebody show us the MRCP picture on the view box?
Yeah, as you can see, the liver is little, I think, cirrhotic. It will be early. With
Yes, quite bulging.
So I am expecting a little difficult case.
Nothing is difficult
With
for
some
you.
adhesion in the GB. So let's see. So I always put 10 mm efficacy, this one. One more line.
Dr. Jayant, have you tried ERCP in this patient? Is it a
This
failure?
case was actually planned for lab CBD demonstration. Whoever is
No, it is
more-
demonstration only or indication?
No, not indication. Wherever ERCP facility is there.
Okay.
As a surgeon, since I don't do ERCP, so I always go for lab CBD exploration. In my institute, I don't have CBD, but if you have, it depends. It is a debatable thing whether CBD ERCP or you go for a lab CBD exploration. But for bigger stones and multiple CBD stones, we prefer lab CBD. And for bigger, yes, 5 mm both. That will do, that will do.
Dr. Pathania, actually there is no ERCP service available in
Okay.
North Bengal Medical College. So
Okay,
every,
okay.
every case
Holding
they
forceps.
either open or lab they will
Plain
do.
gas
They have to.
So this discussion is ample evidence that CBD stone management depends a lot on the availability of facility as well as
Yes.
expertise available. So there is no standard protocol set which has to be followed. It is exactly because of the availability of the facilities in that institute or the availability of expertise. So these are the things that will determine what is the mode of treatment for
Yes, you
CBD
have-
stones.
Always, you know, if ERCP is available, even
diathermy?
little
Diathermy
distance,
cable?
about 20 to 30 kilometer, you
Yes.
can get ERCP because, you know, morbidity is less as compared
Diathermy?
to, especially this case when there's
but-
already
but-
difficult gallbladder with CBD
But the
exploration.
but the thing is that if you see this data of the Northern Medical College patients,
Yeah.
so they are very poor enough, so they cannot
Okay,
afford
okay.
20,000, 25,000 rupees for
Okay,
their
that's
care.
okay. Then it's okay. Then it's okay.
Protocol wise, yes, this is agree that you should try ERCP, then go for this.
For stone more than 1 centimeter, unless you have facility for lithotripsy, industrial lithotripsy, it's difficult to remove those stones.
Professor Basu, actually, for the PGTs, if you ask this question in their final exam, they should say like this ERCP
Yes,
followed
yes,
by.
yes, I agree. I do not disagree.
Sure,
There is
sure.
a book teaching.
Definitely
But
that should be the answer.
That should be the answer. And in our institution, Dr. Saha,
Focus
our
taking.
thing is that 1.5 centimeter is the what line. Below that, we all try the ERCP. Usually, they don't want to do the stones larger than 1.5 centimeter in our gastroenterology.
But you know, there are people who are doing more than 1 point because they have a lithotripter now.
Position?
They are breaking the stone.
Sir, in Raipur discussion,
Yeah.
Dr. Ardhanari's institute, they have 2
Even in
centimeter.
Gangaram, Delhi,
They have
they
2
are,
centimeter.
yeah, they are doing. In my own case, my mother,
Yeah.
she had 30
Jayantu,
well, 3
can
centimeter.
you ask them to
It was
focus on the
broken by
MRCP?
lithotripter.
Go
By-
closer. The
in
camera
Gangaram.
can go closer to the one of the pictures on the right side. One of the pictures
we
on the
are,
right side.
Doing the positioning of the patient.
With the history, we came to know that it's a big stone, 13 mm stone at the neck. Are you expecting a mid-disease there because you can't see the cystic duct there? It's
Yeah,
not well
might get.
enumerated. Can somebody focus on that MRCP there?
Go closer. Camera, external camera, go closer to that arrow. Yes. Yes. Okay.
Lower cuts, please. Lower cuts.
Go down.
Yeah.
Yes, yes.
Yeah.
Fix it there. Somebody's head is coming. Yeah. Okay. Okay.
Yeah.
Keep it there.
Keep it there. Keep it there. Stop. Yeah.
Little more head up.
Perhaps you can see a well dilated CBD. Yeah.
No, cystic duct
No,
is not
whether it
visible
is
yet.
not visible.
Dr. Jayanta, I know you are using the ureteroscope mostly. So are you doing this here also?
Can I aspirate the? Yeah, I have brought my ureteroscope, so I'll try to show aspiration needle.
Okay.
Aspiration needle is there. Yeah, show me that. Right. As you can see, sir, the liver is little cirrhotic and it might be difficult to retract it. I wanted to aspirate the gallbladder because I cannot hold because of the liver also, little firm liver.
I don't think this is cirrhotic. This looks like a grade 3.
Yeah, looks early, but with the loads and all.
Grade 3 fatty liver.
Few small nodules.
Yeah, that retraction you just showed was adequate, I think.
There are some nodularity, Abida.
Yeah, nodularity is there.
Yeah, that retraction is good enough, I think.
No holding, you can hold. You have to hold. Or a gauze piece you give just to tie. मुश्किल हो जाएगा ना instruments.
Dr. Jayanta, what are you tying with the gauze?
Sir, I am tying the instrument because the catch is not holding.
Okay.
It is slipping. So it is difficult to, little difficult case, difficult instruments, little bit anyway. We'll try to manage. Yeah. Yeah. One more. So only thing which differs from normal lab chole is if you are planning for a CVD exploration is the epigastric port. I have to put it a little up and towards right side, right side little more, so that the CVD comes in line with the instrumentations. Like Casper, this is expression, that's okay. I need the diaphragm is ready, meridian, yeah. Plain Casper, please. This is features, I need meridian, yeah. Careful on instrument key na niche. Over here also cats. So you can see here a dilated CVD.
Yes. Very nicely visible here.
Yeah.
Picture is very clear.
So here gallbladder is definitely there will be little some edema because of the obstructed CVD. So I'll try to, you can see the wall properly, the CVD. So I'll try to go a little away and start my dissection. Diathermy, please check. Show me here. So this is the duodenum reverse sulcus. You don't see it here.
There's a small
you
dimple.
Don't see
there.
the cystic
Very small
lymph
dimple,
node.
which is
Probably there is the facial coming here. And just diathermy, please.
Dr. Jan, I think decompression of gallbladder will help you. No?
Yeah.
Pardon, sir?
Decompression. This, if you decompress.
Yeah, I was asking for a aspiration needle.
Yeah, that will help you.
You got the aspiration needle?
Dr. Jayanta, let us see the ICG mode just before you start the incision.
Yeah, this is the ICG mode, sir.
Right.
You can see the CVD properly. You can see it was given almost 1 hour back. So you can see the liver here turning green. This is the CVD. This is gallbladder. Probably there is a stone in the neck obstructing. So that
gallbladder has not become green.
Green dye, yeah.
Okay.
ये क्यों नहीं जा रहा है इंस्ट्रूमेंट not going to. I am just putting the aspiration needle with another port because already I have tied that instrument. I'll try to aspirate the gallbladder. Suction, please. Leaking only. show me properly. There may be some spillage of the bile from here because suction and yeah, it is sucking. It is a yeah. Okay. Yeah, plain Gasper. Yeah, that one. Yeah. Carved Gasper tips. So whatever, yeah, now you can see some dye in the gallbladder also.
Yeah.
Go in little, camera, Abhijit. Yeah, along with me helping is Dr. Abhijit Jena. He is my PG student. Dr. What was your name? Dr. Amjad Esser. Amjad Hussain Esser, senior resident from North Bengal Medical College, and Dr. Rana Kundu. They are assisting me. Keep ready, Maryland, please. Many surgeons prefer, most of the surgeons prefer I think, diathermy working, no, yeah. Diathermy is not working. I need the hook now. I need the gauze piece also for inside, okay? I'm not getting, I cannot reject the CV, no, because of the liver. Yeah.
For the residents and beginners, I must point out this level of dissection that Dr. Jayante is using. It is, you will see that it is at least 3 to 4 millimeters away from the green color of the liver. So it is very high, actually quite high up. It is not at the junction of the gallbladder with the liver. It is totally on the gallbladder and very high up. This is the safe point for dissection. Don't target the junction of the liver and the gallbladder. The entire dissection should be on the gallbladder. Yeah, the cystic duct appears quite wide.
This
yeah.
Oh, suction, please. Suction.
Dr. Jayanta, why don't you go for CBD exploration right away?
After this collapse of CBD and all, once I wanted to go for the cystic, because if there are some small stones after CBD exploration, some stones might come down. So I always prefer to put a clip on the cystic duct before going for the CBD.
Yeah, that's a very important technical point. You get hold and control of the cystic duct first before opening the CBD, so that more stones do not fall into the CBD once you start CBD exploration.
If it is little edematous tissue, with a blunt dissection is always preferable. That's better actually.
The telescope needs to be cleaned a little bit for our vision here. Can the telescope be cleaned?
Hook, please. No need. Morning, sir. Iris does not, sir. I need a gauze piece for inside. That sheep liver is little nodular, sir. Liver. Nodular and early cirrhotic type. Yes, sir. Clean this. Yeah, go in, please. I don't know, gauze piece. Oh, threads and all. You don't have a 5mm clip applicator, no? Give me the harmonic, that Sony Cision. Yeah, hold this. No, no, this is okay.
Are you not going to clip it?
I am using a Sony Cision because I have not made the CVS here fully because of little edematous tissue and I am not getting proper retraction of the gallbladder because of the little firm liver and enlarged lobe. And also there is some leak from the gallbladder side because that aspiration needle was not working properly. You have connected See, I'm not being able to retract the liver, gallbladder properly. Hold this. Give me the hook. That means is it working? Yeah, working. Don't increase too much, okay? No, coming in between. And go here. No, here diathermy is not coming in between. Please switch off the mode, normal mode, give the suction. Yes, normal mode. I'll need it later on a little. I'm not getting the fundal retraction properly because of the liver, okay? That is giving me little problem. Anyway, cirrhotic liver, this is the problem. That and me also. Yeah, go in, please. Going to the gallbladder.
Let us go.
So in between, we can discuss one or two things in the bile duct injury. Though it is not the purview of this operation, still I think it will be easier. Can I ask the panel, starting from the junior most one, Dr. Rudradip Banerjee, what are the general recommendations to minimize the risk of bile duct injury during emergency and elective setup? First you say in elective setting?
In elective setting, intraoperatively.
Yes, definitely intraoperatively.
Yes, intraoperatively, the protocol is to ensure, and if it is not very much edematous, not very bad anatomy, then to look for critical view of safety and just stay above the rubeus sulcus and to ensure Lord Condenson's sign and all these things. But there are variations also. I mean, for rubeus sulcus, yes, if we stay above, we will not go below the rubeus sulcus, but things can go above the rubeus sulcus. So the main thing is that proper delineation is always needed. And critical view of safety is more or less the standard thing, but in acute setting, though it is elective, in acute cases, it is not always possible to go for, we cannot see actually the critical view of safety. So if possible, indocyanine green technology, if available, stay as much possible away from the CBD, dissection away from the CBD if possible. So these are generally done intraoperatively actually.
Okay. Dr. Hiranmaya Bhattacharya, any adding?
Suction, please.
No, actually, I always tell my PGs, stay away, close to gallbladder. Number one. Number two is the anatomy. Nowadays, atom has come, so I forgot the synonym, anatomy, operation, timing. So, American Gastroenterological Society has done that.
I think you talk about practical things. No, I don't want any theoretical one.
Anatomy.
Okay.
We must
So,
see the anatomy
your
there.
point is CVS and rubeus sulcus. Any adding, sir? Next.
No, he will tell. First thing is one should be well versed with something wrong with anatomy. So first is abdominal anatomy has to be taken.
Still bile duct injury occurs.
Secondly, you should know the pathological changes in the gallbladder can alter the callus triangle and critical view of safety.
That is-
Still you want to see, but what to do when it is not visible? That is more important. That what we can do after with the critical view of safety is not there. So you should be well versed with the bailout
Sir,
procedure.
any comment?
Yeah, establishing critical view of safety is most important. If it is not achievable, then being closer to gallbladder, away from CBD.
No, next.
Should be,
Wait.
should be adopted.
Dr. Makhanala Shah, anything to add?
In this patient is getting difficulty in getting into the cystic artery and the cystic duct, so it's difficult.
Suppose it is you got the Meiji syndrome, then
yeah.
What you will do?
In that case, there is another guide that in Meiji syndrome it is difficult to find the cystic duct bile duct junction. In that case, there is a new concept saying that segment 4 line. That means you draw.
That is identification, sir. I'm not talking about it. What you will do? What you will do now?
I'll try to stay near the neck of the gallbladder.
Okay.
And try to dissect around.
Okay.
And keeping in mind that I will not go below the
You can't.
sulcus.
You can't. You failed. You failed. There may be very much adhesions. Meiji syndrome, you can't because there is no cystic duct.
In such difficult situation, it will be wise to open the. Yeah.
So that's called the. You are going for the subtotal cholecystectomy in some cases, right? Particularly in acute setup. And nobody is saying that conversion. I don't know why, but safety. I am talking about safety.
So I missed just 2 points. Sir, one
Can you
is to
give me
see
a
the
C-
posterior lip of the clip applicator.
Okay, that is different issue. That is the techniques.
No.
Approach. We are
Number
discussing
10
on the
will do.
approach. The standard guidelines you have to teach that yes, you try to first
Because we
thing
don't
gold
even have
standard
work
is
it,
CVS.
I'll put it later.
Sometimes it is not possible. Go for the partial cholecystectomy. If not at all possible, then conversion. But mind that conversion does not decrease the incidence of bile duct injury. And yes, your point, intraoperative IOC. Yes, intraoperative IOC is good for this type of cases, not for Meiji syndrome.
So can you change over to once?
So in
ICT
that
mode?
case, no, Mirzi, I will prefer to go for fundus first.
Yes.
That is what is indicated for. Fundus first
So
is,
that's the
will
gallbladder,
rescue
yes,
you.
that's your- some
But
leak
in
was
standard
because
guidelines, sir,
not
fundus
doing
nowadays they are not
cleansed
recommending.
with
They are recommending,
put it
sir,
fire
as a
here.
neck approach. That is partial cholecystectomy.
Later
You
on,
open
I
at the
think,
neck
because I
and
need
lay out the
to hide
stones,
and
and if possible, remove the
See,
whole gallbladder or
Moment,
partially.
moment.
That's
Yeah,
it.
in fundus first, you should be careful that you don't put lot of traction.
Yes.
Because in fundus first, there is more chance of injury in the bile duct because as
No,
you do
if-
fundus first.
If you are careful,
Yeah, yeah.
fundus first will rescue your this
Exactly,
Mirzi.
that is one technique.
for the
agree,
time
but,
being.
fundus
And
first is not always safe.
about the IOC. IOC and IOC,
We know that the NIRF IOC, this is the very important new things nowadays, and everywhere we are showing that. But remember that it is not useful in case of severe acute sclerohepatic cholecystitis. So, and it is also written in literature, there is use of IOC does not decrease the incidence. This is not this theoretical question. What are the reported BDI rate during the laparoscopic cholecystectomy in emergency and elective situation? We will not discuss it.
Okay.
This is very important. The
clip
thing is
applicator?
that
You have a what clip?
even we discuss everything about
Clips
the
you have?
safe lap chole, safe lap chole, safe lap chole, safe steps and so on, bile duct injury will occur. Now the question is that, now Rudro, you are a junior surgeon, you are doing alone in a district hospital, a lap chole, you have done bile duct injury. What you will do that time?
Lights to scope. This is 50 or 0?
Sir, I am fortunate
Focus-
enough to
focus,
get
please.
ample of opportunity in my hospital
I need
at
the
present
focus.
now. So I have also repaired, I have
Yeah,
done
okay, hold this.
hepatogenostomy in undilated duct. So if adequate materials are available, and if and not only materials, and if anesthesia is proper anesthetic setting is there, and proper materials are available like 40 at least 5 krill, then I can go for the hepaticojejunostomy if possible. But if things are not available, then I will not do any more surgical exercise there. Just we'll put a drain and we'll explain this patient.
Better to put a drain
explain
and
this,
refer to a
patient
higher
party.
center.
Where to put the drain?
Yes, sir.
Where to put the drain?
Sir, in this case, when I am leaving such thing open, then I will put a drain in HRPM and in the suprahepatic region, because it can go up to the suprahepatic region and give rise to subdiaphragmatic collection. Because I don't know after how many hours the patient will be operated in the setting, so better to put just 2 drains.
Yes, one is suprahepatic, one is infrahepatic, but most of the time the infrahepatic, and most of the time we get the cases half repaired, half done gallbladder with half done this biliary bile duct repair. That is the most dangerous for the patient and for this operating surgeon too. So good, if you
Needle
expert,
over.
you do yourself. If you don't expert, just put a drain and send this thing. The difficulty of sending this thing, there are very few centers, they do regularly the hepaticojejunostomy for the bile duct injury. So it is the very difficult situation for the peripheral surgeons to send to whom. Yes, sir. They think of, sir, liver transplantation. The liver transplantation, you are anastomotic with the right duct only, with the jejunum. So you can go for it.
Focus, please.
Not for the, sir, it is not this operation for the common surgeons, it's only expert hepatobiliary surgeon, expert.
The problem is in doing a primary HGA in this situation, true diameter is less and there is a higher chance of anastomotic stricture subsequently. Technically you can do, but there is definitely a risk of keeping a stent is difficult in undilated duct. It's very difficult to put a stent in a undilated duct. You can extend
no,
little.
you know, if it is less than 1/3 of the circumference of the CVD, there you can put all these things. But if it is more than that, I think you should never attempt this suturing, this CVD.
Sir,
if it is minor, less than 1/3 of the circumference, then you can do it.
I think, sir, once on a blue moon, you do not venture it, better for the patient safety. Because we all know first chance is the golden chance.
Yes, first surgeon is the best surgeon.
So this is. Now there are. Okay, no. Yes.
Do you use 400 clip or you always tie for a dilated duct? Dr. Jayanto?
Yes, sir.
You are ligating the cystic duct because it's dilated.
No, I always use a clip. Either I am fond of putting a hemlock clip. So here, because I have used the epigastric port, 5 mm plastic port, so I'll clip it later from the umbilical port. just before dissecting the gallbladder out.
In a dilated duct, it's better to put a hemlock clip that.
Yeah,
sits
hemlock
well.
clip that holds better actually. This is little wide also, and LT300 also didn't go actually. So I'll try to put a LT400. This is just to keep the cystic duct secure so that stone doesn't come down into CBD again. I'll put the clips later on because I use a 5 mm clips, usually epigastric port, 5 mm plastic port, because ureteroscope I put through that 5 mm scope, just clean the port.
Have you milked the duct? Have you milked the cystic duct? It appears little dilated.
Yeah, I have milked it already. Okay. It is edematous and little thickened. Still some tissue over it is there, but I would like to not to dissect that area.
Some stone is there in the cystic duct, I suppose.
No, not yet. Clean the port, please. Gauze piece and an artery force. Yeah, this one. This will do, doctor. Yeah. So since I have secured the cystic duct, now I would like to go for the CBD exploration. One important thing for this juniors here, you should, if possible, you can divide the cystic artery, but please never divide the cystic duct, because as you know, gallbladder is the most natural and easiest liver retractor. You can retract the liver along with the intact cystic duct.
Next operation is also ready. So Dr. Om Tatia will show us the fundoplication, a case of GERD with hiatus hernia. So Dr. Sudhi Ravi, please. He will moderate the session with other people. Dr. Sudhi Ravi, please. Sayak, who are the other people?
Thank you, boss. I would like to call my panelists, Dr. Srikantayya, Dr. Srikantayya, Dr. Binod Kumar Jaiswal, Dr. Srikant Kumar Patro, Dr. Srikant Kumar Patro, Dr. Najam Hikamat, Najam Hikamat.
He is not there.
Dr. Deepak Verma. I would like to call Dr. Prakash K.
Sir, you can talk to.
I think, yeah. Hi, good morning. Thank you, sir. Hello.
Hello.
Hello. Thank you, sir. Dr. Sudhir here.
Yes, good morning. This is Dr. Om Tantia from
hi, sir.
North Bengal Medical College, my alma mater. I was a student of this college 40 years ago.
Oh,
and
wonderful.
now I'm back in this college. It's a feeling of homecoming for me in this college. And I think I've seen a lot of changes in this infrastructure. And this is the super specialty wing of the college where I'm privileged to come and operate. This was not there earlier. And this is one of the most beautiful operation theater that I have ever seen in my life. Thank you, the administration of North Bengal Medical College, for giving me opportunity to work in this wonderful place.
Thank you, sir. We are also very much delighted to have you with us, seeing you operating after quite a while. Thank you, sir.
Thank you. And the first thing that I did when I landed today morning was to go into the admin block, pay my homage to the statue of Sushruta, which we were also a part since its inception. And it had a wonderful feeling in my heart. So back here, this gentle lady, 45-year-old female with history of long standing. Can you hear me?
Yes, we can hear you.
Hello, can you hear me?
Yeah, we can hear you, sir.
Because I feel there's a stunning silence here. I don't get any feedback from your area.
Are you
We
hearing?
can hear you, sir.
No, sir, it's just started. Yeah. So can you hear
if
us?
If I don't get any response, I feel scared.
Can you hear us, sir? Hello.
Okay.
Can you hear us? Hello. Hello.
So this
Hello.
gentle lady, 45-year-old gentle lady with a long history of hyperacidity, dyspepsia, regurgitation, and heartburn. Upper GI endoscopy was done, and upper GI endoscopy suggests the G line at 36 centimeter, and of course they have not mentioned about the diaphragmatic indentation. But the picture shows a significantly large hiatus hernia. So we plan to do a Nissen's fundoplication in this patient, and my team is ready with painting and draping. We have at the anesthesia Dr. Malosri, sorry I forgot your name. And I have with me my colleague Dr. Shashi Khanna, Mr. Santosh, and Dr. Deepak. Dr. Deepak, who is a senior resident in this institution, they are with me. And now we are planning our ports. So the patient is in modified French position. The two lower limbs are abducted. I'm standing in between the legs, and patient will be steep head up. With me on industry is Olympus. They are giving us Viscera. You know, this is a 4K 3D system, a wonderful system that I have worked earlier also. Wonderful system, and I have imaging system of Olympus as well as the energy system of Olympus. I have the ultrasound scalpel from Covidian, Medtronic. They get angry if I say Covidian. Eta ki re kalo kano? Recycle naki, change code.
Hello, is it audible there? Hello.
And the head end, the monitor is at the head end, and this is the OT setup. I'll make the port and then come back to you. Meanwhile, you can go to the other theater.
Yes, we will switch over to Dr. Jayanta. AV team, please switch over to Dr. Jayanta. He is showing the ureteroscope and its function, which will be utilized for this scopy.
So hello.
Yeah, Jayanta, go ahead.
Yes, sir. I am using a ureteroscope. This is the smallest ureteroscope in the diameter, around 5 mm, 6 mm diameter. So I am using, camera. Yeah, I have been using this for last almost 8-9 years, both for CVD exploration as well as ureteric stones. So here same angulated eyepiece with camera piece, and this is a working channel. There are two irrigation channels. One is here, one is here. So we can put a basket from here to basket out any stones, or even a lithotriptor from there to break down any ureteric or CVD stones. A light source.
Dr. Jayanta, what is the length of colorectomy you made?
Pardon, sir?
What is the length?
Colorectomy I have made just above the duodenum, in the supraduodenal part, below the cystic duct junction. Colorectomy, you need not to make it very big, too big, because I am using a ureteroscope. It depends on the size of the stone. You know, CVD is quite elastic, so even a bigger stone can come down with a smaller colorectomy.
Yeah, you have taken a stone out, you have seen.
Because I have been using cards. Okay, thank God. Keep it properly, huh? Just to press it. No, not locked.
Dr.
So
Jayanta?
at this, hello?
Yeah, go ahead.
At this junction, we try to reduce the abdominal pressure because I don't have a plain grasper, no fundal retraction towards the left shoulder.
Yeah.
Let it be remains. No traction is required, and you should keep the with a plain grasper. Just remove this, brother, doctor. You remove this, yeah. With a curved grasper, you hold that cystic duct area and I try to push it towards the abdominal, the cystic duct CBD junction, and try to push it towards the abdominal wall, anterior abdominal wall.
Okay.
Pardon?
Yeah, so you're partly lifting and pushing it more medially.
Right, because I need the colectomy to come very near the
Axis of that scope, yeah.
One more is it? No, it is going in. No, connected, but not this one. Loose, yeah. Yeah, white balance, you do please.
Dr.
Yeah, I want to see that this side, this right hand corner.
Dr. Jayanta?
Yes, sir.
Considering the length of the ureteroscope as opposed to nephroscope, do you
Yes, sir.
require to stand on a footstool to get a higher?
Yeah, I have put my epigastric port little, as I said in the beginning, I used to put the port little towards the right and to the up as much possible.
No, my question was about the height of because the length of the ureteroscope is longer, so you may have to lift up your shoulder to.
Yes.
So
Yes,
then
sir.
you have
Yes,
to
sir.
stand on a
That
stool.
that is difficulty, but if you are doing it regularly using any scope, you are comfortable with, you should do it that. Because nephroscope, it is a little diameter-wise like auspice, little wide. So I think ureteroscope, you can do up to 8 mm CBD also you can explore. And only the thing is, it is a thin instrument, so chance of CBD injury is more than the nephroscope. I feel that.
Yes, very true. Very true. One has to be very much more controlled to manipulate the ureteroscope so that it doesn't go and
Yes, make it 8,
puncture
please.
in the opposite side.
8. So I'll need irrigation, full irrigation, okay? So when I go through to the lower end, my movement is like this, and I'll keep pushing slowly. My movement will be this rotatory movement. It is not that I'll just push the ureteroscope.
Very correct.
I have to rotate this just to avoid injury. And the thing is, we are reducing the gas pressure to 8 because I need the colectomy to come near the ureteroscope port. Irrigation, please. Doctor, open up this irrigation. Yeah, this here you
PIP
can.
view. PIP view shows the PIP view. No, the PIP view is not there.
No, it has not gone in.
Yeah.
So that's the.
No, we are not seeing the PIP view. Somebody shows the PIP,
PIP view.
Yeah.
Why it is not clear? Yeah, that's the lower end CVD you can see.
Yes.
So one advantage of ureteroscope is that, yeah, there is another stone down there. I think, yeah, one more stone. So I'll need to basket it out. Either I don't have a lithotriptor here. So please open the basket. I have got a basket. Doctor, Amjad, you have to hold it. Hold it properly. Careful, careful. You don't push it, otherwise the CVD will get torn, okay? So I have to basket it out because I don't have a lithotriptor. It is little bigger stone.
Right. So the practical tip to the beginners, to advance this ureteroscope or nephroscope, whichever you're using, you should not advance it until you see the lumen. Should irrigate, see the lumen, and only then advance it. Because if the lumen is not visible and you try to advance the instrument, it may inadvertently puncture on the opposite side. So
Rightly said, sir.
To avoid that, you should always visualize the lumen first and then try to advance.
We will.
Cholecystoscope, yes, sir. We can do, but it is more flexible but delicate instrument than these rigid scopes. Cholecystoscope, you get rigid also. Abhijit, you come there. Let him hold the camera. You come with the basket. Smart, you have to put it up, huh? Otherwise it will tear off the CVD, okay? Wait. Doctor, you please come to... You come to camera port, I think. Yeah, he will... Yeah, just come there, hold the camera. Yeah, hold this. So basically this is a little bigger stone, just open up slowly, huh? I would have loved to put a lithotriptor here and break it down. Close, please. Close fully. Because basket also might injure the CVD. Open.
Back. Out. Can you hear me? Kalimpong.
Yes, sir.
Can you
I'm Dr.
hear me?
Jivindra, sir. Good morning, sir. We can hear you.
Good morning. So I'll tell you my port positions. These port positions are standard for any upper abdominal surgery. We have 10 millimeter port at the umbilicus for the optics, 5 millimeter port, my right hand working port. This is my right hand working port in which I have sonic season. Is in the mid-clavicular line, subcostal in position. This is my left-hand working port. Shashi,
Hello.
This is my left-hand working port, again in the subcostal position, mid-clavicular line, 5 millimeter. This is my assistant's port, 5 millimeter in the anterior axillary line. And this is Nathanson's retractor, which is coming from the epigastrium. So with these port position, I tell you the anatomy. You can see this is the cusp.
Hello, is it audible there? Hello, is from the hall. Is it audible there in the OT?
You
OT2?
people are audible to me.
Okay. Yeah, sir.
So this is the Kussner's window.
Yes.
I make a small window in this Kussner's window, and I make an incision onto the gastrohepatic omentum, and I go here. One small point. This is the right crus of the diaphragm. Our incision should come like this. In no way it should go like this. That's a very important point. If it goes like this, then there is a possibility that we may injure the left hepatic vein. Quite often we get accessory vessel coming from here going all the way to liver. So we have to be careful, and we divide this. We go up to the apex of the crush, then turn our incision onto the right side, onto the left side. very gingerly we have to make this dissection, and when we are making this dissection, make sure that the pad is towards the left, towards the right. And then we carry on this incision a little more. We carry on this incision a little more and divide it till here. So from here we enter into the lesser sac gauge.
Sir, actually we are supposed to conduct a panel discussion also here along with while you are doing the surgery.
Yes.
We have our panelists also here. So we have Dr. Deepak Verma and Dr. Binod Kumar, Dr.
Very
Prakash, and Dr. Srikanth here. So actually while you are proceeding, sir, actually you also will be giving us some points, but we will do some sort of a panel discussion while you are doing.
Yeah, sure.
Okay, fine.
Sure.
So you said that initially the patient was taken for surgery without a pH metry or manometry. Is that correct, sir? So
there is no pH metry and there is no manometry. Yes, I agree to that. Now the thing is, there are role of pH metry is restricted to diagnosis. This patient is already very symptomatic for GERD, and also endoscopically she is having hiatus hernia.
Yeah.
Along with
I agree.
mild
I agree that point,
reflux.
sir. So let me ask my panelists also whether they agree with that. So Dr. Prakash, what's your take on that? You do the pH metry in all cases, or if the patient is symptomatic, or when will you do that?
As we all know, the pH metry is the gold standard to diagnose, certainly for sure about the hiatus hernia, but it's not practical to do pH metry for all patients. So it is being reserved generally for those with atypical symptoms and those who have suspicion of any motility changes. But if the patient has, what I would say is the patient has significant symptoms, particularly reflux of food contents, volume reflux, and the endoscopy findings are quite conclusive, then at the most you can do a manometry to rule out any motility change, and then you can proceed with. If the patient is young, or if the patient appears very anxious, and if there are atypical symptoms, then there is a role for pH metry.
Okay, can I interrupt? Can I interrupt?
Yes, sir. Please carry on.
This is the right crus. Okay. This is the left crus. Yeah. And I go in the plane just anterior to the left crus. And this is the esophagus. When I do so, you can see the posterior vagus. Can you see the posterior vagus?
We can see that, yeah.
So I lift the whole thing in this plane. This plane is very important. If we don't enter into this plane, then we are likely to enter into false plane. So this is how we enter into this plane, and we join the incision that we had made here. Now coming back to the discussion that we had on the pH metry, can you hold it please? Can you see my grasper now?
We can see that. We can see that, sir.
You can see my grasper?
Yeah. And
now
also
coming back to the discussion that we were having on the pH metry, see, pH metry is gold standard to diagnose the GERD, but also equally important are endoscopic finding as well as presence of presence of hiatus hernia. I agree that GERD may not be associated with hiatus hernia, but if there is a hiatus hernia, we are almost sure about it. Okay.
We agree with that, sir. We agree with you. There is no need of pH metry in all cases. We discussed
and
that.
And what is most important is doing a manometry, because quite often it is associated with, Quite often, it
impaired
is
peristalsis. Impaired
Just a
peristalsis would be there. Agree. But if there is an impaired peristalsis, would it change the management? Would you go for a partial fundoplication?
Yes,
or still
certainly.
will you go for a fundoplication?
Certainly, if there is a what you call motility disorder, if there is a motility disorder, my take would be to go for a partial, not for a 360 degree. And in cases, if we do not have the facility of manometry, that doesn't mean that we will not treat these patients. Yes, we can still treat these patients. And what we can do is, we can do a dynamic barium study, which is very easily available almost everywhere. We do the dynamic barium study and we see, that is of course a very crude method of knowing the esophageal motility, isn't it?
That's true, sir, but actually it said that even if there is an impaired esophageal motility,
if there is impaired esophageal motility,
still Nissen fundoplication can be done.
No,
there are studies on that. No, there's not an argument. So the literature shows
now,
this is
if there is impaired motility, if it is a achalasia, certainly I would not like to do a fundoplication in that patient. But if there is a impaired motility, if we see on manometry, then perhaps I would like to go, and there are significant symptoms of reflux along with hiatus hernia, then certainly I'd go for a Nissen's, not Nissen, toupee.
Your point is well taken, sir. Your point is well taken. But
because, see, the most important thing is, most of our institutions, they do not have the facility of esophageal manometry.
Okay.
So, government, especially the government institutions, we don't have that facility. So, we have to do something. We have to treat these patients. And the easiest way and the best way and the most, just a minute.
Okay. Yeah. So every patient with a hiatal hernia will have a esophageal motility disorder to a certain extent. But most of these patients, after the Nissen fundoplication, there are reports saying that their esophageal motility improves. Some 70 to 80% of them, the motility disorder improves, in fact. So let me ask my panelist, Dr. Binod Kumar. So what's your take on that? Will you do a Nissen fundoplication or a toupee? I agree if there is a scleroderma, if it's completely absent, I agree a partial fundoplication may be done. But if it's only an impaired motility, would you go for a toupee or a Nissen fundoplication?
Go first in all the cases if the patient by endoscopically if you diagnose it a case of endoscopically if we diagnose a case of grade 3 or grade 4 is a very complex condition of this hiatus hernia, grade 3, in that case just we can go for the full circle of anterior or posterior, full circle of fundoplication. Yeah. If the patient has a grade 1 sliding hernia, that can be managed by the conservative means also, but sometimes we have to go for the surgery if the patient has burning chest or burning regurgitation all the time. In that case, just we have to, we can do this partial fundoplication. Partial, whatever the procedure you can opt a toupee or whatever procedure you select.
Deepak, you are the same, or you had to say something on that.
No, as you said,
because some fluid will go there.
Some amount
that's why reason I'm this, no problem.
Esophageal dysmotility is quite common in all all patients with reflux. What we need to understand during history taking is that many patients will have significant dysphagia. In those patients, probably we'll have to be very careful, and the patient should undergo manometry to see whether the esophageal clearance is adequate or not, or if there are spastic esophageal disorders, or if there is a impaired esophageal muscular movements. In such situation, theoretically there is no difference between a 360 wrap or a posterior wrap, partial or complete. But probably I would go for a partial wrap rather than take a risk on the patient to make him dysphagic after the surgery.
That point is very important. If the patient have dysphagia, probably our approach might differ. But if there's impaired, I also have done many of them a 360-degree fundoplication, a very floppy fundoplication, and patient is not having a dysphagia developing after the fundoplication. Anyway, yeah, I'll give it to Srikanth. Srikanth also has to say something about that, please. Yeah.
Here also I'm not getting this.
Actually, Felix Nickel and group, they have done a evaluation mapping of this hiatal hernia surgeries and fundoplication. And according to that, it is actually posterior or a partial fundoplication has level 1A evidence of doing better as compared to 360 fundoplication.
The stone has come out.
That is when there is a completely absent peristalsis. Impaired peristalsis, as it was discussed, all these patients with the GERD will have an impaired peristalsis in the manometry. Anyway, so actually, sir, you have divided
but I don't know, maybe another stone down.
You have divided the lesser omentum. So if you see a left hepatic artery, accessory hepatic artery, would your approach differ? Tandya, sir? Hello? I think we lost you. Hello?
Hello?
Can you hear us? What did you do?
What was the question?
So we saw you dividing the lesser omentum. But
Yes.
if there was an accessory hepatic artery, a left accessory.
If there is a large artery, what I do is I clip it temporarily. If I see that a significant chunk is getting, discolored, then I take the clip off and try to preserve. But in majority of the cases, I may have to divide, and there is no problem in division of that. If there is a very big vessel, then of course I try to preserve. And in that case, the position of the wrap may change either above or below that vessel. Okay.
Yes, sir. That is one point. And the thing is that if the liver is a bit cirrhotic or pre-cirrhotic, or if you feel that there is a parenchymal change in the liver, it's better not to divide that artery.
Yes.
So that's very important thing that if the patient's liver and liver structure also is very important. Now, sir, you have reached here.
Yeah.
Have you mobilized the short gastric artery, or you do it later?
I will divide the short gastric later. First, let me. Patient is light.
So short gastric artery division.
I come to that.
Okay.
Yes, leave it.
Sir, will you do?
I will divide the short gastrics.
You already divide the short gastric.
I will divide the short gastric, not divided yet.
You divide the whole of the short gastric, or only one of them, sir? The first one, or you?
See, I try to divide the few uppermost, but I usually start from this part. And go all the way up. It's patient.
Okay.
Does it really matter if you divide topmost or you divide one or two more?
Yes, sir.
Does it really matter?
That's the thing what we are going to discuss. I feel that actually is better
because
to divide
my
all
main intention is to have a very very floppy wrap.
Yeah.
And for that matter, if I have to divide one extra short gastric, I don't mind doing that.
Exactly. So we also agree with that, sir. Actually, it's better to divide all of the short gastric because that will give us more
I don't be dogmatic.
Mobilization.
I'm never dogmatic on the idea of not dividing short gastric. Now, etar bhetor duke jao.
True, sir.
মুখটা বন্ধ করো
And
এই
also
গ্যাপটা
that would give us a better mobilization of the whole of the fundus,
Yeah.
posterior mobilization.
Yes,
Because the fundus
I'll
will be
show
better
that
seen.
একটু নিচের দিকে নাও, একটু নিচের দিকে দাও।
So your practice
And
also
here
you divide-
I am dividing the short gastric, and we have to be very, very careful about not coming too close to the stomach, a little away from the stomach. This is in contrast to what we do in sleeve gastrectomy.
Yes, sir. So
And here we have to be very careful about the, chhado. We have to be very careful about the posterior short gastric. Posterior short gastric is posterior and really, really short. And that, if that bleeds torrentially. So we have to be very careful about posterior short gastric. Yeah.
So what I practice in my clinical practice, I try to limit what sir has started at the beginning, try to limit my division of the short gastric, and if at all I feel the wrap is not as floppy as I want, then I go and divide again few more. So I try to limit it, but still I have a scope of division if I require.
Okay.
Prakash, yours is-
Here, sometimes we may go posteriorly a little and then come anteriorly. Sometimes we have to come from here all the way here, because we have to be very, very careful. These vessels, they are short and they are quite big vessels. So especially this vessel, you see this vessel, enter here. This vessel quite often is, this one, quite often is short and very thick.
Very prominent one.
So we have to be very careful on this vessel. এটাকে ধরো, টানো, একটু এরকম টানো বাবু।
I saw the discussion on the short gastrics. I am aware that there is literature that without any division of short gastrics, a fundoplication can be done. But in my practice, I routinely mobilize, just like Tandya sir was doing, full mobilization of fundus.
Yes, you can control it with bipolar. Nowadays, bipolar shearers are available, which are very good.
Yeah, but my argument is that what is the point in not dividing that? Because ultimately our aim is to have a loose
and see if I
wrap.
tell you,
so good division of short gastrics is important.
একটু pull করো।
Dividing the short gastric artery makes this
Medtronic has
fundus
paid you, na?
more floppy and more mobile, so that you can turn it around the lower esophagus. And the division of the short gastric artery, either anterior or posterior, will not make any difference in the blood supply of the fundus, because this fundus is supplied by the left gastric artery as well as the few esophageal artery which is coming down. That's why arterial supply of that particular part is not compromised.
Just replace
That's
my
why division does
instrument.
not,
That is the
hamper the
idea.
blood supply.
Replace my instrument. Yes, good.
Yeah, so we all agree that a complete division of all the short gastric artery would aid our floppy niscence, and also more of posterior mobilization of the fundus under vision. Tandya sir, you were dissecting the esophagus down. How much of the esophagus will you dissect?
See, my idea is to have a 4 centimeter dissection of the esophagus, because I want approximately 2 centimeter to 2.5 centimeter of the wrap. So if I have to do that, it's good to have a esophagus of 4 to 5 centimeter dissection.
We agree that. But in case if there is a short esophagus, like a long-standing hiatal hernia, or in elderly
We may have to go for Colles gastroplasty.
How often, Prakash, you did Colles gastroplasty?
I've done quite frequently Colles gastroplasty. Quite frequently I had to do Colles gastroplasty. And Colles gastroplasty, is contrary to the belief. Colles gastroplasty is quite simple. What we do is we fire a stapler like this, and then we tranject it like this. So it's kind of a fundectomy, and if we do a fundectomy, then esophagus automatically gets elongated. It's something similar to mini gastric bypass that we do. Isn't it? Do you agree?
Sorry, sir, because I don't have any personal experience of doing so. Even if the short esophagus with adequate mobilization, it might come down. That's what I feel.
Mostly with adequate mobilization, you get the esophagus.
Yeah, the transhiatal
but
mobilization,
sometimes
if you
may
are
not
really
gauge.
meticulous, if you go as much high as possible, the length should be
See,
adequate.
one thing I understand is, if the esophageal shortening is more than 5 centimeter, then adequate mobilization, even you may not or we may not get enough length of esophagus intra-abdominally. In those cases, RAP migration is a possibility, so we have to be a little more careful in those patients, and it's better to err on the side of Colles gastroplasty than anything. Yeah, press it.
Yeah.
Press it, Babu.
Colles
Yes.
gastroplasty, I think, is Tandya sir is doing, but generally speaking, people go for a good mobilization of the lower esophagus. That itself gives us adequate length of intra-abdominal esophagus. But, and one more thing, even in Colles gastroplasty, thing is that you are, damaging the sling fibers. And instead that it can cause a sort of dysphagia. And also, one more thing is you may not get adequate fundus to wrap it around if you're going to do a nasal fundoplication after it. Doctor, you have anything to say on gastroplasty?
Press it. আমি যেখানে press করে
In this case, just we divide the fundus mainly. Because of this division of this fundus, the esophagus comes down inside the stomach. At the same time, we take few stitches through the hiatus so that it will not go
press
off.
করো না এরকম
And
না
we fix the fundus.
আমি যেরকম প্রেস করে আমি যেরকম প্রেস করে আছি হ্যাঁ বাস পারফেক্ট একটু মিডিয়েটলি দ্যাটস বেটার
In my experience, I have.
Yeah, can I
done
interrupt
a college? Yeah.
on some technical point?
Yes, sir.
Can I interrupt on the technical point?
Yes, sir, please.
So I have divided the short gastrics. In that process, I see how good mobilization of the fundus has taken place. It's a beautiful mobilization of the entire fundus has taken place. Might be a little more on this side I will have to do. Might be a little more. I think we have enough fundus mobilization. We have enough fundus mobilization, we don't need it anymore. So this is the anatomical position and we have enough of it. And we have created a large esophageal window. This is a large esophageal window. And you can see, I appreciate this hiatus, this is a reasonable hiatus. And this is the abdominal aorta, you can see the pulsation. My initial point was that we go anterior to the left crus. If we don't go anterior to the left crus, we may enter into this plane and then that is a bad plane. Okay?
Yeah, yes.
Now I check for adequate mobilization has taken place or not by bringing the fundus behind the esophagus. এটা একটু ধরো bowel holding, Maryland.
Sir, is there any role of doing vagotomy for lengthening of the esophagus?
Maryland.
I couldn't find any literature to support that. A vagotomy to increase the length of the esophagus. Probably now, this is now Tandya sir is trying to bring the fundus. Yeah, vagus are preserved. Both should be preserved. Both the anterior and posterior vagus should be preserved, or else the patient will have a gastric emptying issue. Yeah. So it's not done usually. Now that sling of sir was putting I think it's a Ryle's tube or infant feeding tube to take the esophagus up. That's very important. So that towards the end, when he tried to go for a fundoplication, it will be not on the stomach. It will be on the esophagus. So that sling is very important, and it is very important to keep that sling there, so that the esophagus.
So
and now sir is doing that shoe shine manner. Yeah.
We have adequate mobilization.
Yeah.
This is called shoe shine maneuver. And I leave my left hand so the fundus is not going back. So that means my mobilization is correct. My next step is to do cruroplasty.
Yes.
Okay.
Okay. So the thing is, in this shoe shine maneuver for the juniors, when you do that, the important thing is, as Tanya was saying, that it's not going back when you leave it. And also
Yes, when you leave it, it should not go back.
And when you do that shoe shine maneuver, the esophagus should not rotate.
Yeah, that is again very important.
That's
Very
an
true.
important thing. Yeah. That's or else if the esophagus also is moving, that means you need more of fundal mobilization.
I put a 2-0 ethibond suture into the abdomen, and I'll do the cruroplasty now.
Sir, how important is to preserve the hepatic branch of the vagus, sir?
It is, if you can preserve it, good. If you can't, if it comes in your way, hampers, you divide it. I mostly divide it.
Om sir, can we go to Dr. Jayanta because he's
Please.
Can we shift to Dr. Jayanta? He's finishing the exploration. What do you want?
I am on, sir.
Yeah.
Hold this.
Dr. Jayanta?
Yeah, there is some problem with the, because as I said, I would have loved to break the stone before.
Right.
Yeah, it was a little bigger stone and my basket got stuck there.
Yes.
So somehow I could, show me this clip applicator.
Yes, you could extract it. Yeah.
Yeah, extract it. I have gone down into the lower end.
Yes.
Usually, whenever the ampulla is little patent, I used to put my scope, although it is not advisable, into the duodenum also, just to confirm it. It is usually not advisable. Okay?
Yes.
Because it might
I also
cause.
would not recommend it. We were very happy to do that in the beginning when we started. But we found a couple of cases where we came with
No,
the
because
pancreatitis.
ureteroscope diameter is too small than nephroscope, so probably it goes very easily. That's what
But still,
I found.
we would advise
But
that
still it is not advisable. I would not advise to go into the duodenum.
Yes.
I think there is some tissue there, and better to put a tie only. Okay, because it is little wide. Some tissue is there. I think I will just suture it, that cystic duct.
Okay.
You can see, sir, because I tried to applying a
So
400 mm.
You are confident about the proximal biliary tree exploration?
Yeah, I have shown my assistance. I have gone.
We have been seeing that during the
beauty of ureteroscope is that you can go up to the tertiary bile duct.
Right.
You can remove stones, even a very small stone you can irrigate out, or you can put a basket there. Basket it out.
We have been seeing that.
That is the beauty of ureteroscope, thin scope.
Yes. So now you are removing that 400 clip and then going to suture like it.
No, sir. Even 400 is little wider, the duct. So I'd like to put a stitch on that.
Okay.
Change the camera. And now I decided, because there are some difficulty in the lower end, so I don't intend to put a stent. Although I have brought a stent, I put a T-tube rather. Although T-tube placement, it doesn't provide the patient the beauty of laparoscopic surgery, because the tube has to be there for quite long.
Yes.
With a stent, the patient can go home very easily on second, third day if there is no leak, no bile leak in the drain.
Yes. So now you are planning to put a T-tube and then come out.
I am planning to put a T-tube because there is some bleeding from the lower end. I don't want to put push a stent through that area. It might injure it little more. I'd like to put a T-tube here, sir, in this case. Any preference of panelist or esteemed panelist? What do they do?
We practically see that it is not too much bleeding. A stent would still do the job, I think. I would go for a stent because
Yes.
we can see the lumen ampulla and then the guide wire going through easily through the ureteroscope. Then over the guide wire you can put the stent. I think that itself should be good.
So I can try that.
Yeah. I
But
think you
I
should
would
go
have
for the
loved to
stent
put
only, not for T-tube, because that is what we are demonstrating, the advantage of laparoscopic CBD exploration.
Ureteroscope.
Giving
Yeah. Okay, sir. I'll try to
giving
do
the
that.
laparoscopic advantage to the patient.
Yes, please.
The only condition is probably that the patient has no access to endoscopic retrieval later on. There is no way that the patient can go to an endoscopist later on. Then only I think we should put a T-tube. Otherwise, we can go ahead with a stent, biliary stent.
Yeah, basically that I can show you once more. CBD cholecystectomy. Because when we irrigate the CBD, usually the duodenum and all get distended little.
Right. So as you keep suturing, can we go to Dr. Om Tantia because he's suturing the.
Yes,
yeah.
sure, sir.
Yeah.
Hi, Dandy sir, we are with you. Hello.
And I have put
Yeah.
2 sutures on the
Crus.
crura.
How many sutures will you put, sir? How tight it should be?
I see, that is the main important thing, how tight. You release the traction, and see it is snugly fitting. Okay?
Yeah.
You release the traction and you see it is snugly fitting. That is adequate.
And you do
So-
this kind of mattress suture always, or simple sutures also is possible?
I sometimes I do mattress, sometimes do a simple. It depends upon my anesthesiologist's mood.
And what about the anterior cruropexy, sir?
Anterior cruropexy, in this case, I might put a small suture here.
Okay.
And I will do that.
Okay, sir.
This, I feel, is more of a cosmetic stitch than anything.
And one more thing is, what about putting a bougie? When will you put a bougie? Would you put a bougie at all?
I've never put bougie in my entire life.
Okay.
I use bougie only during my bariatric surgery.
Okay, sir. Okay. So let me ask our panelists, Deepak, would you put a bougie or it's completely?
How do you, sorry? I couldn't hear you. There is no sound. Make it out of my way.
No, I don't routinely
Make it out
use a
of my
bougie during fundoplication. And regarding this anterior stitch, generally it is not required, and it might not.
This anterior suture is usually not required, very rightly said. I think it was anterior suture you were talking about, no?
Yeah.
Yeah, this is usually not required, but it's kind of a cosmetic. देखने में अच्छा लगेगा इसलिए मार दिया.
The main thing is the lie of the esophagus.
That is very important.
And angle of the esophagus. There should not be any angulation anteriorly when you close the posterior crura. So that is the most important thing to avoid dysphagia and abnormal swallowing after the cruroplasty. So that is the most important factor which will dictate where to use the suture and how tight or how snugly you should close the crura.
Now, if you leave the esophagus, if you leave it, you see it is just adequate, very snug. There is enough space here. So I put the anterior suture because this anterior defect or small defect was created because of my incision. So it's better to close it. It was not the natural one.
Will you pass any suture through the esophageal serosa?
Sorry?
Will you pass any suture during cruroplasty through the serosa of this esophagus just to fix it and to prevent the further sliding up of the esophagus in future?
I could not get your question, sorry.
Will you pass a suture during cruroplasty through the esophagus?
No, not during cruroplasty, but I'll pass it during my fundal wrap. During my fundal wrap, I'll pass the stitch. I'll show you. Hold it.
Bougie thing, again, I used to put a bougie after the fundoplication just to see whether it's easily going in. But it's not mandatory, as sir was saying. Sir, you are beautifully doing it, sir. Actually, I still remember you doing it some 20 years back, 22 years back in workshop, the same procedure, the fundoplication, beautifully, and you are still, we were admiring you doing it at that time. Prakash, you put a bougie or not?
No, we don't, as a matter, don't put any bougie usually, unless we suspect any stricture or in the endoscopic assessment if there is any problems. And regarding wide hiatus, where the suture closure is tight, what are the options? Recently, I have seen Dr. Panlival sir demonstrating a continuous type of suturing to address that issue. What is your take on it?
Yeah, I also never tried that, but actually in the literature it said that a continuous suture also can be done, but it's not having any advantage over the multiple simple sutures. Now here for the viewers, the thing is, now sir is taking the sutures from the greater curvature on the left side to the greater curvature of the fundus on the right side.
That is very important, because there is a tendency to take the sutures on the anterior side. That creates a rosette kind of configuration, and that may cause dysphagia. So it's important that the suture on the left side is from the anterior wall, and on the right side it is into the posterior wall.
Exactly. So it should be from the greater curvature to the greater curvature, the suture. Again, Dr. Prakash made that point of the crural
This is my middle suture. This is my middle suture. It comes only through the two stomach walls. The upper suture will come through the wall of the esophagus also, to prevent upward migration.
So, crural repair, would you ever use mesh? Or
I have done on a few occasions when even after complete mobilization, I could not approximate the crura. Those are the situations where I have used a mesh, and there you have to use a bilayered mesh, or what we call a
a composite mesh.
Composite mesh.
Yeah.
And you have to slit the mesh in order to accommodate the esophagus.
Yes. Yeah. But when will you use it? Actually, if the defect is more than 5 centimeter, or is there any cutoff like that? You measure that?
See, I have not done any measurement. If I feel that the crura will not get approximated properly without traction, so those are the situations I have used mesh.
Mesh, okay. But generally, people are losing interest.
Only very few occasions might be
Yes.
Might be in my entire career 4 or 5 times.
Yeah, generally it is not needed. Yeah,
Chances of migration of mesh is seen. Have you seen or not?
Migration of mesh.
Yeah, in the
migration of wrap I have seen.
Yeah.
Two cases I have seen migration of wrap, but mesh I have never seen migrating. Yes, I have seen mesh migration in inguinal hernia. Yes.
Sometimes mesh migrates to the posterior mediastinum. Have you encountered any such case?
Rather than migration, mesh can erode into the esophageal lumen, because you'll be partly closing the diaphragmatic crust, and then to bridge the gap you use the mesh. So mostly it's because of the rough edge of the mesh chronically irritating the esophageal wall. It can erode into the esophageal lumen. Such cases are being reported.
Posteriorly it goes to the posterior mediastinum sometimes.
I have a doubt to ask, like if you are using a polypropylene mesh or a composite
Now,
mesh. So
now one technical point. Hello.
Yes, sir.
One technical point. See, there is enough esophagus. So what I do now is I take it up, take it as high as possible, take the stitch here, and while I'm taking it up, I take the stitch accordingly onto the esophageal wall, and similarly I come back here. So this prevents the wrap migration. So this is, I think this was the question you asked earlier.
no, sir. He was asking about fixing the wrap to the crura or esophagus to the crura.
I'll fix the wrap to the crura. I will fix the wrap to the crura, to the right crus. I'll fix it.
Sir, my question is whether to use a composite mesh if the polypropylene side or the polyester side remains onto the esophageal wall. Is there anything wrong to that, sir? Or can we use any other thing like a titanized mesh or like biosynthetic mesh in that place?
That is better. Titanium mesh is always better. And if you put this, what you call, polypropylene thing towards esophagus, that is not desirable.
Agree, sir. And thing is now mesh as far as possible. People don't use mesh. A direct chloroplasty would be sufficient. So mesh is losing its popularity. Initially, the Bard company was marketing a mesh with PTFE on one side, and it's a custom made for the hiatal hernia repair. It's no longer available. I think there's no much users for that. I think that's the reason.
Those Bard messes which were yes,
yeah.
yes. Those messes I don't know whether they are available or not.
Sir,
are they available?
Sir, there is a biosynthetic mesh from Bard that is available, sir. It is a absorbable mesh, but a delayed absorbable in 1.5 years. So that is an option, sir. As well as titanized
For hiatus
mesh.
hernia.
For hiatus, it can be used any place, sir, in infected cases as well.
But ज़्यादा नहीं, ज़्यादा.
Yeah, that's an expensive mesh, but custom-made mesh for hiatal hernia was available. Now it's not, their company is not marketing it. That's the point we were trying to raise. So 3 sutures you put. So what's the length of this fundoplication, sir? How many you have?
About
like
2.5 centimeter.
2.5 centimeters of length.
And see, it is enough loose. Okay?
That's very good, sir. Yeah, we could see that.
You
It's
pass
very
the
floppy.
instrument.
It's very floppy.
Absolutely floppy.
Very
That
floppy.
is important.
That's important. So the fixation of the rhabdocura, sir, maybe you may be doing it after this, but there is some controversy on that, saying that it's not the esophagus, the GE junction is a dynamic structure, and you shouldn't fix it.
Yes,
And,
that's always a question raised against fixation of the mesh.
Yeah.
But if you take into consideration the advantage and disadvantage of fixing the wrap versus not fixing the wrap, I think the balance tilts more in favor of fixing the wrap. Don't you agree?
we agree with you. I also fix
So
it.
now I fix it. I fix it here. I fix it here.
Yeah. The lie is a natural lie. The fundus was just resting over there, and Tandya sir is taking a stitch onto that right crus. Deepak, you do this fundus fixation?
I fix all the wrap to the crust. And another thing is that I make sure that the lie of the wrap, that suture line, is between probably 11 to 1 o'clock and is not rotated to any side. That is another important point we should be sure about. Especially
So
after
do you
fixing
agree
it.
to this suture line?
Yeah, definitely, it's great.
Anyone who had dealt with a migration of the wrap into the thorax?
We have had 2 cases of wrap migration into the thorax.
Those people definitely will put a crural fixation to the crura, because it's very difficult if it is completely migrated into the mediastinum to take
See,
it back
one patient, I tell you, the patient after a week or so, he had wrap migration into the crura. He came to us with severe pain chest, and on investigation we found that the wrap had migrated to crura. We did a laparoscopy. We could not reduce the wrap which had gone up, so ultimately we had to do a thoracotomy. Second patient, the patient had a fall and had a chest injury. And it was 6 months after the surgery. The patient had a now we release the Nathanson.
Yeah, Nathanson, yeah, we released the Nathanson, that's fine, fantastic.
Now we take a 5mm scope and remove all the garbage that we have left inside.
Thank you, sir. That's
This is out.
Very, very beautiful demonstration of fundoplication. So before that, before we moving, how do you manage postoperatively, sir? Because
this is very important.
when you feed the patient.
Yes, this is very important. Tomorrow morning, I'm a little conservative. Tomorrow morning, we feed this patient liquid, and I feed the patient right in front, right in front of me. I advise the patient to drink very slowly. One very important thing that I would like to tell for the post-operative part, because you ask the patient to sip very slowly, and quite frequently these patients sip with a straw. Now, once you start sipping with a straw, every time you sip, you also sip some amount of air which is present in the straw. That ultimately leads to a gas bloat. And the patient in the post-operative period says that I have a gas bloat. So never ask the patient to sip with a straw, always discourage to sip with a straw, number one. Number two, we always ask our patient not to have aerated drink. Aerated drink means any soda, any Coca-Cola or anything aerated, we ask them to avoid it. We ask them to avoid beer. So, because with these aerated drink, the patient gets a gas bloat. So these are the things, and we advise the patient to eat slowly. My standard practice is asking the patient to make 20 pieces of a chapati, and each piece to be chewed 20 times. This gives a feeling of early satiation, weight loss, because these patients are quite often more than 30 BMI. So early satiety, weight loss, and the patient is also having eating pleasure. And I advise the patient to keep a glass of water by her side. Whenever she gets transient dysphagia, drink a glass of water and ask somebody to pat the back. That goes away.
Anything to restrict activities, or do they take rest, intra-abdominal pressure initially for a few weeks at least?
No, I ask them to restrict to avoid constipation. That is very important. And another thing that I ask them to avoid is Kapal Bhati in yoga. I ask them to avoid Kapal Bhati in yoga.
What's that, sir? Kapal Bhati, we... Oh, okay, okay. Valsalva, something like Valsalva thing, yeah, okay.
Kapal Bhati, you know what is Kapal Bhati? No. Kapal Bhati is taking breath in and then forcefully, suddenly forcing it out. Like Ramdev ji always shows you on the
Thank you.
medicine usually, no. Thank you.
Thank you, sir. Thank you very much. Please give sir a big applause. Thank you for the organizers, and thank you for the panelists. Thank you. Thanks.
Dr. Jayanta? Dr. Jayanta?
Hello?
Yeah, we are with you now.
Yes, sir.
We have seen
I
you put the
decided.
T-tube. Yeah.
Yeah, I have decided to, because the theme is the guideware.
Okay.
Yeah, so I'll put a T-tube now. I have already put an T-tube there.
Yes.
So I'll just close the choledochotomy. I use interrupted sutures usually,
Right.
3-0 vicryl material or polysorb, and then interrupted stitches. I keep the T-tube on the top. There's maybe some controversy. I don't know about the opinion of panelists whether to keep the T-tube up or down.
Yeah, I was going to ask you that. We have
Yeah.
seen you that you are
Yeah.
keeping it in the upper end of that choledochotomy. So
Yeah,
what was the
ultimately,
reason? What was the reason why you have chosen that?
I feel it more easier to stitch the lower part of the, just below the CBD, that T-tube. I feel it more easier to put a stitch there than rather than putting it on the top of the T-tube at the end.
Yes, it is quite evident from the way you're suturing that
Yeah.
the telescope which is coming from the umbilical port, it is coming
Yeah.
from below. And so
Yes.
the lower portion of the incision remains exposed to you nicely for suturing.
Right.
If you put the T-tube on the lower part, the upper portion will be obliterated by the T-tube which is going up.
Right, sir. That's
And
what I said.
Yeah.
It is difficult. And if you put another 5 mm port in the left upper abdomen, it makes this, you can see this is the epigastric port. I have not used this for stitching because it is already on the right side and towards a little up.
Yeah.
So I prefer to put another 5 mm port in the left side abdomen for the needle holder. It makes your life very easy. Switch off.
Do you always do interrupted sutures or you do continuous
I
sutures?
prefer, sir, interrupted. I don't have any this one, but I prefer interrupted. If I am tired, and this one I prefer sometimes to reduce the time of stitching. I put continuous suture. What is your opinion, sir?
Yeah, when the CBD is very nicely dilated and thick wall, I think the continuous sutures are also good option. And
Yeah,
what about barbed sutures?
I don't have any personal experience, sir, but many does it, barbed sutures.
Yeah.
Continuous stitch with barbed sutures. And I feel when you give a continuous stitch, the edge of the CBD comes together and causes little, apposition remains little problematic. I don't know, probably who are doing always continuous suture, they may not have, they might do it little in a better way than me. Go in. For the beginners, the movement of the needle is very important, not to injure. Along the curve of the needle, you have to rotate your needle just to take out from the tissue. I am getting little difficulty because of the height of the table. See, it is not going in.
Your
Go in, go in,
collocotomy
go
is
in.
quite low down, so it's no matter
Yes.
you switch from above or below.
Pardon, sir?
Your collocotomy is much below the 60 dot junction, so
Yes, yes.
it's no problem that you switch from below also.
So you prefer to start from below, sir?
Yes, yes. Here you can do it. But standard teaching is you usually stitch from above and keep the T-tube down in the end of collocotomy.
Yes. The last stitch is very important. Sometimes when you put a scope into the CBD, it might tear off. Although you can see the lower margin very nicely, it might tear off behind the duodenum. So that is very important. That's why I said you should reduce the pressure and your movement of scope should be very rotatory movement. Very slowly, gently you have to push in the scope. So if there is tear, you might have to retire the retroperitoneal part sometimes. Or I include the duodenum sometimes along with the stone along with the coledoco CBD wall.
Right. So the last stitch you include the duodenal wall.
Not always, sir. If there is little tear or something,
if you suspect that
yeah,
it is
if I suspect. But you have to make sure that it is not a very long tear. So that's the lower end of the.
Yes.
Yeah, you can see. So one more stitch should do, I suppose.
Yes.
Is that okay, Zugindra sir?
Yeah, yeah. I think that's. That should be enough.
Or a Maryland also. So you can see bile in the T-tube. So I have put the whole of the T-tube inside. Then I'll bring out the long end of the T-tube later on through a 5 mm port.
Okay. Have you encountered peritonitis after T-tube extraction in a patient?
Yes, sir. Very recently, it was a hugely dilated around 15 to 18 mm, probably long-standing. It was a very thin CBD. So there are multiple stones, and the color of the bile was white in the CBD also. When I exposed, there was little infected bile with little pus. So I removed the T-tube after doing a very nice cholangiogram. It was showing dye passing going nicely into duodenum.
After how many days?
After 4 weeks.
4 weeks?
So, yes. I was expecting some problem, and she was, believe me, she was a patient of a husband of a nursing superintendent in our hospital. So,
it always
he
happens.
developed, yes, I have to send for ERCP to another center. They usually, I didn't want to do any second operation in my institute because of the VIP category of patient. So they did initially laparoscopic drainage, wash and drainage. Then they did this ERCP. ERCP was seeing that rent. Still that rent was there.
Okay.
Needle holder.
So that is one complication we can avoid if we put a stent.
stand, right? Go here. So here is the CBD around, so I'll put my stitch here. There was some controversy, I think, whether to cut the gallbladder and stitch the CBD in a recent AMASIECON. If you suture the cystic duct stump,
Ramesh
whether
Ardhanari sir was saying that we should divide it and suture it.
But I prefer in continuity, stitch in continuity.
Yes, I also prefer the same thing because then
I don't know, this is my preference. I don't know about other panelists.
No, I also prefer the same thing. My contention is that we can use it to retract.
Figures, please.
We can use this continuity to retract the cystic duct and place the suture more appropriately. Once if it is cut and then it is released, then it is very difficult to get the margins completely sometimes.
Yes,
in a very inflamed and thickened situation.
Yeah, I'll just, that suture is short, I don't know. I'll just put a test, then I'll prefer to put another free tie.
But normally what we find is that once you put one suture nicely, then the cystic duct becomes narrow enough for a clip to go through.
Yes,
and we put a clip, if possible, slightly proximal, and that should do the job, rather than tying again.
I would have happy with a 10 mm hemlock clip, 10 mm applicator with a hemlock clip.
Sir, Rakesh Khan from Everest Hall. So actually, you can also give extracorporeal suture to the cystic duct.
Dr. Jayanta?
Yes, sir.
The question is extracorporeal not.
Yes, many uses it. I don't have personal experience, sir. I always give a intracorporeal, I prefer.
There are multiple options. Extracorporeal knotting and doing that is one. Another thing is what you can do is now, because he has already sutured it once, you can divide it and then put an endo loop.
Yeah, we can put an endo loop, but endo loop is not available, I think.
Yeah, so that is those are the possibilities that can be used. A simple 400 clip or a vascular clip, hemlock clip, or you can do an external knotting and push it down, or you can put an endo loop and then close it after dividing the cystic duct.
So, important thing to remove a needle is to hold the suture, not the needle, near the needle end, and pull it out. Needle came. That's ficryl, remaining ficryl was there, suture, ficryl. The thread was there. I have cut that. Give another ficryl if you have. 2020. I think the choledochotomy is quite safe, sir. Yeah, cut this.
Would you inject some saline and check whether it is?
Yeah, I'll see. I'll bring out the T-tube and then irrigate also a little bit to the T-tube so that we can see for any leak. If required, we can always put another stitch. Go in. Yeah, you have to hold it a little here.
To all those who are contemplating to begin with laparoscopic CBD exploration, one prerequisite is that they should be well adept in endosuturing. If you are not confident about endosuturing, it is not going to be practical to start laparoscopic CBD exploration.
So what is your opinion of the panelists regarding primary suturing of the CBD?
In a patient who has underwent a ERCP earlier, this is very good. There is no chance of leakage because sphincter is already having a sphincterotomy. And second is, if you have a duct and you have done a good clearance and no distal obstruction, primary closure CBD is very good. We have done number of occasions. Most of the time we are doing a primary closure only.
Yes, for beginners, I think it is always better to put a drainage, either a T-tube or a stent, if they are well versed with putting a stent. Going. These instruments through the port is little difficult. Instrumentation, no, I don't know. This port, 5 mm steel port, not smooth. When you pull this, you have to be very careful. Sometimes it gets torn and injure the liver. Where is the other end? This one? This one, no? Yeah. Other cases finished?
Yes, that side it is finished. I would like to ask the panelists what is their thought on CBD exploration. In the present times, is it appropriate to do blind CBD exploration? Meaning there is no visualization or there is no preoperative cholangiogram, but you do CBD exploration, keep a T-tube and come out. Blindly, just a Desjardins stone extraction forceps, irrigation, put a T-tube and come out. Is it adequate enough or safe enough? Can the other panelists give some opinion?
Okay, seizure please. Going. Seizure second? No.
Yeah, the question is, in the present times,
do we have a
CBD exploration that was done in the past, mostly done in the past, without visualization of the inside, either a choledochotomy, even in the open case.
It has already been done.
Yeah, so this exploration without visualization or preoperative cholangiogram. You just do blind exploration, keep a T-tube and come out.
Or
yeah, which was the usual practice in the earlier days.
I forgot about this.
So should we still advocate that procedure or should we abandon it? That is my question.
I think we should not fiddle with CBD unnecessarily.
Microphone.
Hello? It's not. Hello?
Hook.
So, unnecessarily CBD exploration without any indication. This is what you meant?
Not indication, I'm saying
multiple
blind
yeah, that's okay.
exploration. Where you're not seeing inside, only you're palpating and you're feeling.
Palpation. Palpatory method.
Yeah, palpatory method.
I don't think so. I think so. We have so many other good technology available. Why we should adopt the same crude method of palpating?
This is you are doing all the time.
Go in.
In our setup, I don't have a facility for intercholangiogram. I don't have a cholecystoscope. What we do is we explore, we do a good clearance, pass a bougie, irrigate.
In all the cases you do?
Because I don't have intercholangiogram.
Can you make an endo bag from cloths?
While I'm doing, I have to rely on that.
Just tie the
You know,
end
in
of the.
open era, we used to palpate.
Yes.
We used to palpate. If we feel stone, then only there were
But what I
different
feel is,
indications
see,
for
while
opening.
doing laparoscopically, we has to have some.
Any cloths.
Open is fine. You are palpating, you are doing good irrigation. In laparoscopy, that.
Any cloths.
वैसे इंट्राऑपरेटिव ना आजकल प्रोब होता है सबका
Come in,
जो अल्ट्रासाउंड आते हैं इंट्राऑपरेटिव
If you
वाला
want to have a laparoscopic CVD exploration and completion, you have to have some visualization. Open is fine. You are palpating.
Open is fine. Not for
palpating with
lapro.
hands. You are passing a bougie, going to the duodenum, seeing it nicely. Yes, going.
मैं कह रहा हूँ डी एटलीस्ट इंट्राऑपरेटिव अल्ट्रासाउंड प्रोब तो लगा लो.
Even with that, you miss.
I think intraoperative ultrasound तो you can use.
Yeah, that is again very difficult. Intraoperative. It is
No,
not easy to do
it's difficult,
ultrasound. But what my thinking is that in the present times, at least one laparoscopic surgery set should be available in all medical colleges, which can be used for visualization of the inside. And any scope which is either a hysteroscope or a cystoscope or some scope should be available, which can be put into if the CVD is larger than 15 millimeters, you can put the laparoscope itself. If you don't have a 5 millimeter laparoscope, you can put the 10 millimeter laparoscope also inside and visualize. So I think in the present times we should advocate to at least see, look inside and make it as clear as possible for the patient, benefit of the patient, rather than leaving it for another procedure next time if there is a retained stone. So even in open surgery we can put in a scope and then do. That is my thinking. Yes. Exactly. From in the future, in the future, as we are going to treat CBD stone problems, we should always try to visualize. That is what I am trying to say. Whether it is in open surgery or in laparoscopic surgery.
So show me the stones.
Imaging technique, during operation, we are just blindly putting forceps and extracting and then putting a T-tube and coming out. Without doing cholangiography, without choledocoscopy, we are not sure whether the stone clearance is complete.
I think least one can do is the intracolangiogram.
Suction, please.
Normally, do you do anything like that? Most of we don't do it all. If there's any intrahepatic stones.
I'll need plenty of irrigations also. Abhi nahi, just to irrigate the abdomen. Stone. Withdraw. This is not stone, this is blood. No ventral tissue. Is that thread? One more is there. One more is there. Two, yeah. Two I have put. Plus the GB stone. 3? No, GB stone fell down. Yeah, big stone. Suction, please. Yeah. I told you, no? Okay. Irrigation, please. Yeah, irrigation. Where is the irrigation now? Just finishing. I'll irrigate and put a drain. I'll have to see that quality go. Yeah. Irrigate. This is very difficult. Yeah, irrigate, please. Port closure you can do, no? No, no, no.
Dr. Jayanta?
Yes, sir.
There is a discussion here regarding latex T-tube versus this PVC tubes. What is your preference?
I think that previously available T-tubes, they were quite good. They causes more fibrosis and form the tract better.
Yes.
Yes. So what I said.
But the younger generation are probably not going to see those latex tubes.
Hello? आवाज नहीं है क्या? हाँ, Dr. Jayant? Dr. Jayant?
Dr. Jayant?
Dr. Jayant?
No, we are disconnected.
It's okay. You give the irrigation for.
Hello?
Jayanta, can you hear us?
Yes, sir. I can hear you.
Yeah, yeah.
So we are asking you, this T-tube you are using made up of PVC.
Yes, sir.
For how long you are going to keep it? And I think a drain is a mandatory.
Yeah, I always keep a drain. T-tube.
You remove T-tube first or drain first?
No, drain first, sir.
Drain? That's wrong.
Is that, sir? I don't know.
In my point of view, many times you remove T-tube and people, they come back with peritonitis. So
that's what we were discussing just some time back, sir.
So, latex is okay. That you can take a risk with that, but not with PVC. The PVC, you remove the tube. If you have not kept the drain, people are coming back with peritonitis. Not all, but 1 or 2 cases. Then they have to, put a laparoscope, put a drain, or do a laparotomy in emergency.
Exactly the same thing happened to me, sir. We were just discussing.
So you start putting drain when you are using these PVC T-tubes.
Sir, I keep a drain.
No, but keep a drain, remove T-tube first and then drain later.
Then how long you keep the drain, sir?
Just for 2 days. Observe, do ultrasound, rule out collection, take out the drain.
No.
2 days, not more than 2 days. 2 days.
T-tube, when do you remove, sir?
2 weeks.
And drain after 2 days of that?
Yes, maybe 17, 18 days.
Okay.
I do that because I have seen how resident is busy in doing, peritonitis, doing laparotomy or put a laparoscope and put a drain to remove.
Yes, sir.
Because this PVC, the fibrosis is not that much.
Yeah, that is the dreaded complication of a T-tube removal, after T-tube removal.
So you start doing that, what I'm telling.
Yes, sir.
We feel quite safe with that.
Then patient, I usually remove the T-tube when I put this type of T-tube after 3 to 4 weeks, and I always do a T-tube cholangiogram before removal. But still that patient had a very nice cholangiogram, still he had leak.
So you
Yeah,
start
irrigate
following this, what we are telling.
See, how we are coming back to the scare one, people are saying the complication of drains. Don't put drain. And now here we are recommending leave drain for 3 weeks.
Not 3 weeks, go 3 weeks. Or 2 weeks. 17 days.
Head up, please. Yeah, irrigate, please. Give some grasper. Keep the drain ready also, 28 drain. देखो ये नहीं जा रहा है. I don't know, this doesn't enter, no. See? T-tube, sir, one single. Irrigation, please. Yes. Somewhere it is leaking actually. Yes, suction, I was using irrigation only. It has come out too. The port has come out, yeah. Yeah. Please. Please. First guess. See the lever. Yeah, put irrigation. Irrigate, please. Yeah. Go in here. Let me. We'll give him. Sure. No need. It's okay. Give me the Maryland. Maryland, please. Show me the end of the T-tube. Okay. Yeah. So I'll bring out the T-tube now from here. Withdraw the port a little bit. Yeah. Okay. 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 Get me a 5 cc syringe with some saline. With some distilled water or sterile saline, okay? I just wanted to see flush. Huh? ICD wanted to. That's large type of thing is coming, okay? Yeah. Fresh, no? Throw that, throw that. Throw that and put it there. This is very small, okay? You can see, no? But on vision, under vision, you see 4, 5 saline. Yes. No, I brought a stand also, but there is some injury type and no guide. Mosquito artery you have? Mosquito artery first. See only that 20. So media.
Jayanta, you're yet to remove the specimen, right?
Yes, sir.
I would have removed the specimen first before pulling out the T-tube.
Because I have to change again to 5 mm to 10 mm, that's why, sir. But because I have got only one 10 mm port.
Understood.
The umbilicus one.
Understood. No, the reason would be because when you are manipulating the anterior abdominal wall to extract the specimen, T-tube may
come out. Yeah.
accidentally come out.
Yes, that's a very valid point, sir. I hardly use a T-tube, so I'll put the T-tube little loose inside.
Yeah, you can push it a little bit inside before extracting the specimen. That will be better.
Yeah. Just go in here. Yeah, just slowly inject it. Yeah, that's okay. So I have injected saline.
Yes, we could see that.
So there is no leak.
There is no leak. Wonderful.
Yeah.
Very nice. Very nice. Excellent.
Thank you, sir. I'll just carry on. I'll remove the specimen and that put a drain there.
Okay. Thank you. Wonderful. Excellent demonstration of the
change.
Yeah. Okay. Thank you. Thank you, Jayanta.
Thank you, sir. Off cricket.
under the guidance of Professor C. Palnivelu as the Congress President, Dr. Suresh Chandrahari as the Chief Patron, and with the help of all Executive Committee members of the AMASI. The organizing team is led by Dr. Lakshman Shastri as the organizing chairman, Dr. Jagdishar Gaur as the organizing secretary, and Dr. Lishmi Kant as the organizing treasurer. The organizing team is working very hard to make this conference as one of the best AMASIECON. The 4-day scientific program is charted out with a lot of planning and care. The leading national as well as international faculty will be a part of this conference. There will be surgical demonstration of the laparoscopic procedures as usual. Apart from this, there will be a lot of other academic events that is going to be useful for both postgraduates as well as the practicing surgeons. The latest developments in the field of minimal access surgery will be incorporated into this conference. Apart from the academic feast, there will be a good hospitality that you can expect from the Hyderabad. Hyderabad is centrally located and well connected. So altogether, this conference is going to be of very high standard. So please don't miss it. Do register for this conference as early as possible. We all expect you to be there in Hyderabad in the month of August for AMASIECON 2024. Thank you.
friends, I am Dr. Deborshi Sharma, the President Secretary of Association of Minimal Access Surgeons of India. On behalf of the association, we'd like to invite you all for AMASIECON 2024 to be held in Hyderabad from the 15th to the 18th of August in Shilpakala Vedikam, High Tech City, Hyderabad. As you all know, AMASIECON is a conference where live surgeries are demonstrated along with didactic lectures, debates, state-of-the-art orations, and we always get a very good industry support. But along with that, this year we are planning for pre-conference courses on the 15th of August, and ultimately making it a full combination of conference plus other things which you can expect in such kind of a mega event. This will be the 19th time the AMASIECON conference will be held, and for the second time it is being held in Hyderabad. Initially it was held, earlier it was held in 2007 in Hyderabad. So on behalf of AMASI, we would like to welcome all of you to be coming to Hyderabad from the 15th to the 18th of August this year, where you can participate in a mega carnival. Thank you all. Thank you very much.
Dear friends, AMASIECON 2024 is going to be held in Hyderabad between 15th and 17th of August. This conference cum workshop going to be very exciting. We are going to have live surgeries all 3 days on different procedures, basic to advanced, laparoscopic and robotic surgery. Here we have a first time introduced interactive technology for which every one of you can interact with experts, both national and international. And there are award sessions. You can participate and win best paper, best video and best oral presentation awards, and avail attractive prizes. There are going to be special courses and hands-on programs, and you can choose your own choice and you can update yourself for your future. And this future is going to be a robotic and artificial intelligence surgery, and that latest information, all information you can get it in this conference. Last year time in 2006, first time fellowship convocation held at Hyderabad for F-Mass course. Now this year again,
Saisha, 2015. No. जिसके पास कौन सी कंपनी है? आगे से मेट्रॉनिक सब बंद. मेरे को सामान नहीं देगा तो मेट्रॉनिक बंद. जाओ. Okay. एक बार ये स्कार दे शशि. एक बार देख. सर से एक बार छोड़. एक बार छोड़ शशि. दे 5 दे. 5
लाइट बंद হবে কি
हाँ एक यहाँ पे ये 5 करूँगा, इसको 10 में कन्वर्ट करूँ, हाँ ऐसे भी कर सकते हैं। नहीं मैं सोच रहा था इधर से जाता ना, हाँ ये यहाँ पे है, इसको 10 करने से परफेक्ट ट्रायंगुलाइजेशन होता। हाँ यहाँ नहीं, इसको 10 करूँगा, इसको 5 करूँगा, तो परफेक्ट ट्रायंगुलाइजेशन हो जाएगा ना। पाँच अच्छे, अरे 5 अच्छे, 5 अच्छे না এটা নয়, আমার ওটা লাগবে, তোর সোনিক সোনিক সিজন কি কোথায় গেল, শেষ হয়ে গেছে। देख थंडर बेटी यार वो अनस्टेराइल है ना तुम्हारा, चल दे इसको फैल्सी को काट देता हूँ, फैल्सी काट देता हूँ। छोटा सा नहीं प्रीपेड करूँ, हेडलॉक की जरूरत नहीं है इसे, दे এই হাতটা একটু উপরে করো, ডান পায়ে দাও, ডান পায়ে, আরে ডান পায়ে দাও না একটু, হ্যাঁ ঠিক আছে চলো। এইটা তো যাচ্ছে না রে সন্তোষ, এটা দিয়ে তো যাচ্ছে না, এইটা এইটা দিয়ে যাচ্ছে না, তুই অন্য একটা দে, দে এটা দেখি। काट देता हूँ इसको, काट देता हूँ, वहां तक ग्रास कर देता हूँ। কি হচ্ছে বারে বারে? আর তোমরা অ্যাডজাস্ট করতে জানো না? কি হলো? ও ঠিক আছে, প্যাক প্যাক করুক, আমি কাজ করছি। যা। পোর্টটা বার করে নিতে একটু, ডান দিকের পোর্টটা। আর কিছু করবে না এখন, ও প্যাক প্যাক করুক গিয়ে। আচ্ছা, भगवान जाने, सब लंच करने चले गए होंगे। और आपने लोगों को भूखा मार दिया। हो जाएगा, करना पड़ेगा। बेटे कादिर रे ठीक है। এটা কাজ করছে না রে তোমাদের থান্ডারবিটটা। দেখি की है तो चैंचा मुझे दौड़िया बंद करते हैं ना, चिल्लाते हैं ना बाहर में लोग। देख कि रे लोड शेडिंग हो गई। छोड़ छोड़ काट देता हूँ इसको। সন্তোষ 15 প্রোলিন নিয়ে ওটাকে গোল করে নে 12 সার্কুলার করে সেলাই দে সেলাই বিলক না আরে আমার অপারেশন কেউ দেখবে কি কোথায় গেল সোনু ওটা গলায় তো একটা পরিয়ে দিয়েছে যথেষ্ট এই সোনু কি আমার অপারেশন কেউ দেখবে ওখানে
স্যার
কেউ দেখছে
গুড আফটারনুন স্যার অভিষেক
বড়া আমাকে একটা পরিয়ে দিয়েছিস আর পাত্তা নেই
गुड आफ्टरनून सर
गुड आफ्टरनून
सर अभिषेक हियर घर का आदमी देख रहा है सर
आई डोंट नो
सर very few people in the hall
nobody in the hall कोई बात नहीं यार चलो লাঞ্চ করতে গেছে দুজন আছে ও যথেষ্ট 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 ঠিক আছে নো প্রবলেম চলো এই মেস দে তাড়াতাড়ি কাজ সেরে দিয়ে বাড়ি যাই দে না ঠিক আছে আরে হলে মাত্র দুজন আছে তাহলে কোনো অসুবিধা নেই বেঁচে গেলাম না এই এটা সন্তোষ কি হলো রে कौन बैठा है?
सर मैं बैठा हूँ सर, अभिषेक।
ओ तू बैठा है क्या?
यस सर।
क्या कर रहा है वहां पे बैठ के?
सर्जरी देख रहा हूँ सर।
तब तेरे को छोड़ के चले गए क्या?
नहीं सर, है सब लंच कर रहे इधर और
अच्छा,
कुछ बाहर कुछ।
चल कोई बात नहीं, तूने कर लिया?
हाँ सर।
এটা ভুলভাল আছে, ঠিক আছে চল। এই আমাদের নিডল হোল্ডার আছে তোর কাছে? হ্যাঁ wait. পনেরো পনেরোটাকে 12 সার্কুলেট করে নেয়। আবার কি হলো রে? Why this happens with me only? Why not with Palni Velu? I'd be happy if this happens with Palni. हाँ যা ইচ্ছা নে রে বাবা। এই নীল হোল্ডার আর দিবি না আমাকে, আমাদেরটা দে। অভ্যেস নেই এই নীল হোল্ডারের। দে কাছে। इसी से मार देंगे दूसरी वो भी। हाँ the attack there on those attacker. हाँ ऊपर टिका देता हूँ फिर कर दे। ऊपर टिका देता हूँ पहले। अच्छा कटा बाजे रहे না না সময় আছে मेरीलैंड दिल्ली ना बदमाश जान वो ना तो ठीक है ठीक है ठीक है ठीक है नो इशू देख मत नर्व देख लिया मैंने मेरीलैंड मारूंगा दे मारूंगा, पहले नीचे मार लेता हूँ। चलो नीडल होल्डर, हाँ नीडल होल्डर ওটা দে আমাকে, ওই ওই মেরিল্যান্ড দে একবার। মেরিল্যান্ড লুপ করা দরকার নেই, এমনি নট মেরে দেবো আমি। জি বাবু ঠিকঠাক হয়েছে তো? হ্যাঁ কি তুই লুপ পড়িয়েছিস নাকি? কি এটা? ও আচ্ছা, এই হাতটা একটু উপরে করা যাবে? আমি ত্রিভঙ্গ মোরারি হয়ে দাঁড়িয়ে আছি। থ্যাংক ইউ, কাজটা আগেই করে দিলে আমার কোমরে ব্যথা হতো না। Position इसको इसको ब्लॉक कर लेते हैं। अच्छा इसको कर दूं। क्या क्या कर दूं? ठीक है खास बात बांस हो गया, बांस हो गया। सर सर ফ্যাকাল্টি সার্জিক্যাল ফ্যাকাল্টি কে আছে এখানে? এই তো আমরা আগে খেয়াল করিনি, এই দেখুন we did not notice, আমরা তো তাহলে এই অপারেট করাটা উচিতই হয়নি আমাদের, তাই না? হ্যাঁ তো ঝাড় হয়ে যাবে পোস্ট অপারেটিভ। বস এটা তো ইউ হ্যাভ টু লুক ইনটু ইট, অ্যান্ড আদারওয়াইজ বদনাম হবে যে এখানে ওয়ার্কশপে করা হলো না, বলছি উই হ্যাভ টু লুক ইনটু ইট, আদারওয়াইজ বদনাম হবে যে ওয়ার্কশপে করা হলো ইনফেকশন হয়েছে। বাট আমার মনে হয় উই শুড put her on anticox. बांधने की जरूरत क्या है? कोई खास बात नहीं, चल ठीक। अरे यार कोई हाथ ताली तो बजा दो, देखा ही नहीं।
Yes, sir, we are watching.
तो हाथ ताली तो बजाओ। चलो, थैंक यू। মোমেন্টামে একটা মাল আছে। এই কোথায় ফেলবো রে? এটার উপর রেখেছো, সরাও সরাও সরাও, তোমার মালপত্র সরাও। সেভেনেরটা আছে এই এক্সটার্নাল কম্পোনেন্টটা, ওকে? এই একটা বড় ইনফ্লেম কম্পোনেন্ট আছে, ওকে? এবার যদি দিতে যাস তো দে, কানেকশনটা দাও। হ্যাঁ, হ্যালো হ্যালো।
Yes, sir.
Yeah, hello.
Hello.
Yeah, this is Dr. Sandeep Ray from OT1. Can you hear me?
Yes, sir, we can hear you.
Okay, now I'll just give you an external picture, okay? There is a little thrombosed component at 9 o'clock. See, you can see that?
No, sir.
Camera dhara. See, there is a little thrombosed component there. I'm just doing the external examination at the moment, okay? OT1. So there is an inflamed skin tag along with, I think.
Yes, Dr. A.
Yeah. Can you see the external view?
Yes, we can see.
There is an inflamed skin tag.
Yeah.
With a little thrombosed component here. Yeah? See?
Yeah.
Okay? And there is again a little inflamed component here with a large piles here. So it's not following the classical anatomical distribution of 3, 7, 11. Rather it is at 9 o'clock here. And it is at 4 o'clock here, 4, 5 o'clock here, okay? Now we go internally. Now, this is not going to reduce, okay? This is grade 4, right? So we go internally now, see how it looks like inside. Laparoscopy light source আছে?
Can you have the view of the inside?
Inside view we won't get, I mean whatever they can show.
Yeah.
Now that's my proctoscope, light source আছে? Just one second.
What is the finding inside?
Yeah, finding inside is with the OT light. Here we go. Well, there is prominent internal hemorrhoid at, again, not classically 3 o'clock, but 3, 4, like that. 11 o'clock, there is one there. Okay, 7 is clean. So internally, there isn't much at 9 o'clock where you had that inflamed skin tag with nearly thrombosed piles. Okay. So it's more of a sort of circumferential. So what we plan to do here is we'll do because it's circumferential, we do a stapled hemorrhoidectomy and then take care of these two
separately.
Okay.
Okay?
Okay.
স্টেপলারটা খোলো, স্টেপলার প্যাকেট অত ভিড় করো না ওখানে, স্টেপলারের প্যাকেটটা খোলো, ওখানে ছিল, ছেলেটা কোথায় গেল?
Dr. Ray.
Yes.
Please demonstrate each and every steps for the juniors while you use the stapler.
Absolutely, absolutely.
Have you done some kind of anal stretching? No.
No, not needed. Not needed. I'll tell you why. Okay. খুলে দাও, একটা একটা করে নিয়ে নি। রাইট, ওকে, সাদাটা দিন, আস্তে আস্তে দেবে, পরে দুটো দিন, ওই দুটো, ওকে, ওটা দিন, ওইটা ওইটা ট্রাইফ্ল্যাক্সটা, হ্যাঁ। Okay. Can you see me?
Yes, yes, we can.
Okay. This is the obturator or anal dilator. Okay.
Okay.
This is 34 millimeter. This is 34 millimeter. কেন ওরা তো দেখতে পাচ্ছে এখান থেকে, আমার মুখে দেখা দরকার নেই।
Yes, 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 we can see.
This is 34 millimeter. So this is going to do a 34 millimeter anal dilatation. So you don't need to do a finger stretch. Okay.
Fine.
After you have done the anal dilatation, this is the anoscope.
Yeah.
This is the anoscope. Okay.
Okay.
And this is the triflange with marking inside. So you are going to take the mucosal, submucosal purse string bite with the guidance of this triflange. Okay.
So how much proximal from the dentate line you should go?
It is exactly the same principle I had demonstrated the FG HAL. Okay. So this is going to be a continuous FG HAL basically, right?
Okay.
So you will take mucosal, submucosal bite. Hey, aste. You will take mucosal and submucosal bite at least 2 centimeter, if possible 2.53 centimeter from the dentate line. Because the idea of this operation is taking a cylinder out from the anorectum, which is 2 centimeter in length, 1 centimeter above the suture line and 1 centimeter below the suture line. And the stapler anastomoses the defect. So it is basically not an end-to-end anastomosis, but a mucosa submucosal resection and anastomosis done by the stapler. So because you will have 1 centimeter down cut from the suture line, your suture line has to be at least 2 centimeter above. Otherwise, your staple line will be very close to the dentate line and it will be extremely painful to the patient. You have to understand that up to the dentate line, it is sensory and there is pain sensation. Okay.
What happens if you go more than 2.5 centimeter?
Well, that is not going to serve the purpose.
Okay.
Because as we know, the division of the superior hemorrhoidal artery occurs higher, right? And that is the best place where it all truncates into the arteriovenous anastomosis. Okay.
So ideally you have to go to 2 to 2.5 centimeter above the dentate line.
Absolutely, yeah.
And
So this is the
dentate line is well seen when you put your transparent obturator.
Absolutely.
You have to put some jelly, I think.
Yeah. It will go. Now normally if you don't have a thrombus piles, you try to reduce everything together. Now it has gone. Okay. And you have to wait for 2 minutes for a gradual anal dilation. So this is our anal dilation. See, 2 fingers. Yeah. See?
Sure.
2 fingers. You can see. So it's no point doing a Lords.
Okay.
So this is Lords. সিলনটা খুলে রাখ। এথিলনটা পড়িয়ে রাখো, এটা লাগবে শুধু দেখার জন্য, আর রাখো না। হ্যাঁ রাখো, see actually if you see now all the external components are reduced very nicely, right? See,
Yeah.
see,
But
yeah,
but
agreed.
Yeah, but it may come back again when you take out this obturator.
No, it will not, because after you have done your staple, because you have resected 2 centimeter of the mucosa, submucosa,
it will get pulled.
The prolapse is partially pulled.
Yeah.
And further fibrosis over a period of 2 months to 3 months ensures that everything is taken back. So the advantage of stapled hemorrhoidectomy is twofold. One, it follows the principle of FG Hall. So it is basically disconnecting the arteriovenous anastomosis above and below, right? Exactly like Boehringer-Kreil principle in esophageal varix. And number 2, because you are taking a 2 centimeter cylinder out, it corrects the prolapse. So physiologically, this is a fantastic procedure. Okay, so we have done. See, now all is reduced. Reduced, huh?
Yeah.
Okay. Now again jelly. Now I am putting the anoscope. Now putting the anoscope is not very easy. Duto dry mop. There are certain tricks. Dry mop. So again,
You have to keep on rotating.
Rotating and pulling the buttock. Yeah? It has to go in. Half go nahi chalega.
Full go.
Full go.
Then you have to take suture and fix it.
Yeah, exactly. So it hasn't gone in yet. Now it has, no, not yet. Male patients, narrow pelvis, sometimes difficult, but we'll manage. My patient উঠে যাচ্ছে, আমি বলেছিলাম বার করে রাখতে। Okay, we'll see how much we are in. দেখি ছাড় না হয়নি। যাবে আরো। দেখি সরো। Jelly. The obturator is going in easily, but here because the anoscope is little shorter.
And there is some thrombospile as well.
Yeah. এটাকে টান না, ওখানে ঠেলিস না, এটাকে টান, এটা টানলে ঢুকে যাবে। I think we are in now. Okay, এরকম ধরো, good. Select. Now ideally it should be fixed at 4 quadrants. উল্টো ধরিয়েছে না? So now I am fixing this anoscope with the buttock skin. এই নিডলগুলোর কাজ করা খুব মুশকিল হবে। Ideally you should be using 10 Mars silk.
Yes.
But I'm afraid it is not there. এই কি নিডলগুলো দিয়েছেন ভাই তো।
And you should take a bigger needle.
Yes, 10 Mars silk is the best one. This is actually the needle holder is okay.
Getting rotated. Is it round body?
No, it's a cutting needle 10 ethylon.
So why it's not?
বড় needle হয় না 10 ethylon, ছোট needle কেন দিয়েছেন? We'll manage. দেখি নাম্বার 1 Mars silk লাগে, টেবিলটা একটু তুলে দিন।
Because fixation is very much important step.
Well, this is the most important step.
Yeah.
টেবিল একদম maximum তুলে দাও। This is not rotating, right? নিডল হোল্ডারের জন্য না, নিডলটাই ছোট দিদি ভাই, নিডলটাই ছোট, এই নিডলটা হবে না ভাই। আরে তো
ডক্টর এ
just one moment, নিডলটা বড়। এই let me just settle down a little bit. I'm struggling with the size of the needle.
Yeah, you ask for a bigger needle or good needle holder, I believe.
नहीं है बाबा वही प्रॉब्लम हो रहा है বড় নীল দাও বড় নীল এই নীল চাবে না এটা তো বুঝতে হবে এই আলোটা দেখাও না টেবিলটা ঠিক আছে এ তো যাচ্ছেই না এটা আরে ভাই বড় নিডল দেখো হ্যাঁ এটা দিন দেখি একই তো সাইজ মনে হচ্ছে দেখি সরু এই আলোটা হয়নি আলোটা দেখাও ভাই I've got a bigger needle now so I think I'll manage this time okay you have to fix it at 4 quadrants okay this is the single most important step পরে আগে ফিক্স করতে দাও আই কেটে গেল আলোটা দেখাতে বলো আলোটা দেখাতে লাইটটা ফেলো ঠিক মতো এইগুলো না সিল ছাড়া হয় না কেটে যাবে এগুলো কাঁচের উপর তো কেটে যাবে এগুলো থাকবে না আরে ঢিলে হয়ে গেলে অপারেশনটাই হবে না you should be using number 1 or 10 mer silk but anyway we'll manage with this is number 1 ethylon wait kar এখানটা ধর হ্যাঁ এটা ছাড় এই জায়গা হ্যাঁ টুথ ফরসেপস দিন আমাকে টুথ ফরসেপস দিন ধারই নেই মারা খুব অসুবিধা হচ্ছে এটা দাঁড়ান ভাই দাঁড়ান কথা বলবেন না ভীষণ অসুবিধা হচ্ছে দেখি সরো আলোটা এখানটা ফেলো ভাই আলোটা এখানটা ফেলো যে আলো ধরে আছো সে আলোটা এখানটা ফেলো এই বাঁধাটা সব ভাই ওটা হয়ে গেছে এটা ধরুন I'll show you everything once I'm just settled with the anoscope.
Sure, sir, sure. You take your time. Be comfortable.
এরপরে তো শুধু এক হাতের খেলা বুঝতে পেরেছি কি বলছি আগে এগুলো মেরে নি বুঝতে পেরেছি কি বলে একটা ওই উপরের হাতটা কি করবে কাছি দাও অ্যানোস্কোপ বেরিয়ে গেলে শেষ অপারেশন বুঝতে পেরেছি কি বলো মিস্টার দেবো tooth forceps the problem is if I try to make it too tight the ethylon cuts through.
Yeah, that's why now.
Snaps. Because it's against a hard surface, so the first knot cut through. Good.
Anteriorly you are going to fix now? Anteriorly also?
Oh, yeah, sure. You have to be careful with this bite because urethra is not far away. Okay, this patient is already catheterized, so that makes my life easy because I mean post-op we don't have to put a catheter. টাইট করছি না, করলে পাট করে কেটে যাবে। Okay, so we have fixed the anoscope. তো ডানারটা নিয়ে জাস্ট এই নাম ধর, এটা ছেড়ে দে, এই উপরটা ধরলেই হবে। ওকে, হেড ডাউন আ লিটল বিট, আনবি না, এটা আনবি না, এই তোর একটাই কাজ, শুধু আর কোনো কাজ নেই, দ্যাটস ইট। হেড ডাউন আ লিটল বিট। নাও সি, আর ইউ উইথ মি?
Yes, yes, we are with you.
Okay, so this is the first quadrant. On to first দিন। এই কি করছেন? হেড ডাউন বলছি তো, টেবিল ডাউন করছেন কেন? টিল্ট, হেড টিল্ট, হেড ডাউন, টেবিল ডাউন বলিনি, হেড ডাউন। তাহলে টেবিল নামলো কেন? হ্যাঁ, দিস ইজ মাই ডেন্টেড লাইন।
Please show it.
This is the dented. The advantage of this anoscope is this anoscope covers up to the dented line. It covers the anoderm, you know.
Okay.
So where it ends, if you have put the obturator with the anoscope properly, the anoscope will cover
The dented line.
Yeah, anoderm. So this is my dented line. Okay. So quadrant 2. This is my dented line.
Okay.
This is my dented line. Okay. Quadrant 3. That's my dented line. And quadrant 4, you can see it better. This is my dented line. You can see that?
Your head is obstructing.
Okay. Can you see that? That's the dented line.
Yes, yes.
Okay. Right. ভেজা গজ, এই আলোটা এখানে চলে এলো কি করে, পেছনে চলে এলো কি করে আমার, দেখি ভেজা গজ দিন, নন টু প্রসেস, ছোট ছোট গজ দিন, বড় গজ দেবেন না, কেটে দিন। See the instrument I used while we were doing the laser, see enema material is coming. Now when I pull out, can you see the dented line? See? See dented line? Yeah, when I pull out, you see pink, whitish, dented line, dented line, dented line, dented line, yeah? So this is just for cleaning, okay? Right, okay. You can see it better now. See, dented line.
Yes, we can.
Dented line, yeah? This is very important because your measurement should be directed towards it, right? Now, এবার আঙুলটাকে একটু নামা আঙুলটাকে, এই দুটোকে একসঙ্গে দাও, that's it, okay? Now I am going to take the stitches, total table down, সেলাইটা দাও। Now with this instrument, the stapler, কি হলো? Stapler একটা এ আছে দেখুন। ওটা ঢুকিয়ে নিলেন কেন? অপারেশনটা শেষ হয়নি তো, দেখুন প্রোলিন আছে, দেখুন একটা, ওটা খুলুন। Now with this you have a double-ended
Proline.
I'll show you. Proline, yeah. 1-0 usually.
Yeah.
I'll show you. This is lotus. This is 0 prolus. So this is equivalent to our, I mean, proline is again a commercial name. Okay. So this is 1-0 polypropylene, 26 mm, half circle, round bodied, double armed.
Okay, sir.
The first thing you do is you stretch it, okay, so that there are no kinks. Stretch it, okay. You don't need to use both the needles. So what you do, mosquito, আটেরি দিন, খুলে রাখেননি কেন এগুলো, আটেরি দিন, দেখুন একটা। So I fix one end here, right?
Okay.
Can you see? You can see, table down, table down. Now the idea is take 2 bites at each quadrant. So minimum has to be 8 bites, if not more. Okay?
Okay.
এটাকে এরকম করে রাখ না, বুঝতে পারছিস নাকি? এই হাতের ইউজ নেই কোনো, এরকম টিপে রাখ। That's it. So that's my dented line. So 2 centimeter above. So the bite is exactly like a FG HAL. So this is, so you can calculate actually here it's 3 mark. So 5, if I take, that's 2 centimeters. So that's my first mucosa submucosal bite. First bite. 2 disadvantages of these bites. 1, it bleeds sometimes, and number 2, sometimes there may be a hematoma. I mean, nothing can be done about that. If that is so, then you press a gauge for a minute, then it becomes okay. Okay, so that's my first bite. Follow that. That's my second bite. Now, how do you know that this is an adequate mucosal submucosal bite? Not less, not more. When you take the needle out, there will be blanching at the tip. That is your guide that your needle is at the right plane. So you have taken the mucosa along with the submucosa. Am I clear?
Okay, yeah, clear, sir.
Okay, so I'm coming to the next quadrant, and again follow. কিছু করো না, খুব ভালো যাচ্ছে, ছেড়ে দাও, আস্তে দে। Okay, the bheja gauge half. Now if there is some bleeding, you put a gauge.
Sir, there is a question that
Yes.
when you turn out this endoscope and take the third bite, it should be in the same line or a little bit above or below?
Which one?
That fasting line.
Fasting line should be at the same level, but it is always better to err on the higher side than on the lower side.
Okay.
Because lower you don't want to come.
Yes. And the line you will be marked by your 2 centimeter from the.
Absolutely, absolutely. So if you are taking a bite, take it above, not below, please. Okay. So now quadrant number 2.5. I've taken 4 bites till now. And it should not lock. Okay, now quadrant number 4. Okay, now here it's a bit difficult, so what you can do is you can do forehand like this, or you can do backhand like this, a bit cumbersome. I will show my way. I stand up, I come this way, okay, and then I do it this way. Can you see me?
They have given the 2 needles so that you can operate from both sides.
No, I tell you, I have never used the second needle, ever.
Okay, most of the person, even I. But they have thought that if you do from both sides, you will be at the same level, I believe.
I don't think so. Is that Nishit?
Yeah, it's not required. Yeah. But still they have given.
Well, this is the difficult bite, then again it becomes easier. আপনি ঢিলে করছেন কেন? ও আপনি এখানটা ধরুন না। Okay, I think I have done the bad bit. Right, chair back. ধরুন অন্য কেউ চেয়ারটা। Okay, quadrant 4 now. ছেড়ে দে ধর এরম হ্যাঁ আর আপনার রোল শেষ আপনি আর ধরবেন না ছেড়ে দে এই ধর একটা হাতে এই দুটোকে এইখানটা চেপে ধর দ্যাটস ইট okay. So I think we have already taken more than 8 bytes. Doesn't matter. If it is more, it is better actually. Are you following it? Hello? Hello? Hello?
Hello?
Are you following it?
Yes, we are following.
এটা ধরুন হালকা করে এইখানটা Please let me know if there is any point to be explained. I'm happy to do it.
Sure. Definitely, we'll do it.
I don't know whether you can see it or not.
We can see in this
blanching.
Yes.
Blanching. Yes. This is what I was talking about, the blanching. Okay?
Yeah. Blanching on the mucosa.
ছেড়ে দিন
Blanching on the mucosa.
The blanching ensures
that you are in the submucosa. You have taken adequate bite.
Absolutely.
Pull the shade, na?
না আপনি ছেড়ে দিন তুই ধর তুই বাঁ হাতে ধর আমার মুখের সামনে এনে নয় হ্যাঁ So we are slowly coming back to the first point.
Yes. So I believe this is the last, and you will take one more, I think, if required.
We'll see. The only thing is to avoid locking. Okay? ছেড়ে দে না হয়নি.
So it should cross the first stitch, or you should remain proximal to the first stitch.
Pardon? এরকম ধর না তুই ধর হ্যাঁ
You will try to cross the first stitch, or you remain just close to the first stitch.
No, I cross the first stitch.
You cross.
I cross. I'll show you. See this blanching. Okay?
Yes.
That is important. Okay? I have to make a comment. This procedure, এদিকে না জিনিসটা বোঝ এই okay?
Yes, sir. What's your comment?
I have been doing this procedure since 2002. Okay? This is one instrument. I think I was the first one to do it in Kolkata actually, 2002. I learnt it from Dr. Jai Singh Sindhe from Pune. So he has a huge number of staple hemorrhoids. This is one device where the cost hasn't gone down adequately. I mean, the cost of this is a disposable device, obviously, and the cost should have been much less. I think one deterrent to using this, see, I've just crossed it, okay? I've just crossed it. Can you follow? আটকে গেল আবার চলে গেছে Hello?
Yes, sir.
Yeah, I've just crossed it, okay?
Put a finger inside and see the pulsing effect.
Yeah, 100%, okay? Now what you do is first thing to know that you have the first thing to know that you are actually no interlocking is when you pull this should come. See, this is coming.
Yes.
Okay? So, but I have tightened it. So what I'm going to do is now put my finger in and dilate it and ask my assistant to put his finger in. Put the finger in. Put. Now I'm tightening. Tight pacho. Okay, again dilate. So my assistant confirms that the purse string is working, and before he comes out, he dilates the purse string again because you have to push the stapler now. So this was it. So that's my okay. এরকম সব সময় ঠেলে না এটা মিস হলে হবে না কিন্তু সারাক্ষণ এরকম ঠেলে রাখতে হবে অপারেশনটা এরকম লেভেলে হচ্ছে এরকম নয় ওকে রাইট মাঝখানে রাখ রাইট So clean it up a little bit. You can use water as well. So that dilates my purse string further. Now I'm with the stapler. Happy up to this? Happy up to this?
Yes, sir, clear.
Okay. Now I'll show you the stapler.
Please.
This is on the principle of an EEA stapler used for low colocolonic anastomosis.
Yeah, colorectal anastomosis.
Yeah. Colocolic anastomosis or anal anastomosis. The only thing is the anvil is fixed.
Yes.
There you have the anvil separate,
Yeah.
right? You have to attach it and then fire.
Yeah,
The anvil is fixed. So this is the anvil, this is the guard. And there is a marking. So when it's open, there is no mark. Now when you close it, you will see there is a orange line that comes. So orange line come up to the last point means your staple is fully closed. Okay? You can see this orange line?
Yes, sir, we can see.
Yeah. So I'm opening it again. And there is a guard here so that even if you accidentally press, now the stapler will not fire. So I've opened it fully. Assistant only.
Stapler is fire only when you close the everything.
Oh, absolutely, absolutely. Even after you have, now you put some jelly again at the tip, right? Now gently you pass the staple. You will find a give. I am rotating it and it goes and then there will be a give. Puck, there will be a give. Puck, not happened yet. Puck. Yes. No, that happens. Now ever, you pull it and then you tighten the purse string. This is difficult to see, but see, I have tightened it, right? Pull. So I am tightening the purse string now. Now you wonder, this has happened once or twice to me because this is polypropylene, okay? While you are putting the knot, this snaps. Okay. Dangerous. You have to put the purse string again. Vicryl would have been better for this sort of knot, but the problem is if you use Vicryl, then the purse string will not. The purse string will not do well. Yeah. Yeah. So you have to be very gentle with this knot. 5 knots. So basically, what has happened now is the anorectal mucosa and submucosa is tied around this rod. Okay? Up to this point. Anvil is above, stapler is below, and we have tied the anorectal mucosa and submucosa around this rod. Now what you do is...
You take out the suture from that hole.
Yes. So if you are Kachi. Support karo? No. So I've cut the needles now because it's not needed. Now there is a sort of suture puzzle like thing. So you pass it here. Non-tooth forceps. Artery forceps. So I'm just passing the suture. This is for traction, nothing else. You follow this? Hello? You are following it?
Hello?
Yeah, follow that?
Yes, yes. We are following.
I pass the sutures through the windows. The only purpose of this is to actually give a pull when you are fire the stapler. Okay? So you make a knot at the midline. Midline. Just rakhun ar kichu korte hobe na. Rakhun. ছেড়ে দিন বেরিয়ে আসুন. So you hold it here, Kachi. So this is for pulling. Okay. So, non-tooth forceps or gauge? So I'll clean it up a little bit, doesn't matter. Up to this, everything clear?
Clear.
I'm just cleaning the blood out. I mean, it doesn't matter actually. Just if you can see it actually. I don't know whether you can see it now. Okay, now my assistant ওটা ছেড়ে দেবে হ্যাঁ এই কাপড়টা চলে আসছে কাপড়টা ওখানে যাচ্ছে কেন এরকম হালকা করে ধর আপনি এরকম টানুন এটা বেশি জোরে টানবেন না এরকম এরকম Okay, now I am ready to close the stapler. See? So now I am taking the guard off. Okay, I'll close it first. Now, the idea of this suture through the window is to give traction.
Sir.
Yes. Yes. Hello? I'm closing the stapler now.
Yes, yes. Please show us how.
Yes, please carry on. Please carry on. Any confusion anywhere? Now I'm tightening it. How do I know that I've tightened it properly? This orange will come.
Okay.
I'll show you.
Yeah.
I'll show you. Hey, bhai, camera takane dekho. The orange has come to the bottom. It will not come to the complete bottom because you have got the mucosa, submucosa in the cup.
In the cup, yes.
Okay.
So it is tight now?
Yes, it is tight. And I wait here for 2 minutes. I'll wait here for 2 minutes. ঘড়ি দেখো ভাই কেউ একটু আছে ঘড়ি আছে ওই 2 মিনিট That ensures less staple line bleeding. There should not be any bleeding at all, but there are sometimes little staple line bleeding. I mean, company says 1 minute, I usually keep it for 2 minutes. I still haven't opened the lock yet. Now I'll open it. See? You can lock it. So even if I do, the staple will not fly. Huh? This is Prosec by Lotus. Meril has one called Miras. Ethicon has got PPH stapler, and Covidian has got PPH stapler. So there are at least 4 in the market I know. Ethicon was the first pioneer.
Yes.
Followed by, I think, Meril, then Lotus, and then Covidian, Medtronics.
What is the cost of this stapler, sir?
A pin price down. Not less than 20, boss. Oito packet ta bhai. Packet ta ke niye gelen. Not less than 20, I'm sure. That is the MRP.
Yes.
But obviously the hospital buys 22,500. But if the patient buys directly, then it's little cheaper.
Yeah.
I mean, it comes down to as low as 12,000, I can tell you. Okay, এই 2 মিনিট হয়ে গেছে বোধহয় ভুলে গেছো আগে বলে 3 হয়েছে Okay, so 2 minutes over. Now I unlock this and now I am going to fire. Okay? There will be a kachak sound that makes you happy that okay, it's fine. Okay? So kach. Now once this scotch is gone, you hold it for 30 seconds. So I've cut it and now I'm holding it for 30 seconds. Again for staple line hemostasis. Are you following it? Hello?
Yes, we are following.
Oh, I can see you, Manoj. Good afternoon.
Good afternoon, good afternoon. You are doing a great job.
30 seconds over, so I release it. Now, Now this, what should I say, flange at the end, you have to make two and a half turns, okay? So this is
in the
half,
opposite side.
this is 1, 1.5, this is 2, and this is 2.5, okay? So that ensures that the cut portion is loose and comes out easily.
Yes.
And then what you do is you take everything out together, okay? So a scalpel din, eta dhor babu. So I cut all the stitches. Baba, dada baba. 1, 2, 3, amata sara. Amata dekhi sabdan. 4, okay? And then by corkscrew movement, you take everything out. Take everything out together. No force, huh? Right. Once it is out, the first thing you do is take bheja gauze ta din. Bollam bheja gauze ready, boro size. You put a gauze piece inside, okay? Bheja no ota. And take the silk sutures, 4 here, out. The second thing is take this anoscope out of the assembly, and then you take the donut. একটা টুথ একটা নন টুথ দিন এটা দিন তুই একদিক ধর Manoj?
Yes, sir.
Yeah. So checking the donut now.
Yes.
Tol.
Yes. Good and complete.
See,
all around, yeah.
That's the suture line. 1 centimeter above, 1 centimeter below. Ghora. All around. I think it's a fantastic donut actually.
Yeah. Very good.
I'm very happy. Chalo. This goes for a biopsy routinely. No questions asked.
And all the prolapse pile has been pulled up.
Ab dekhega. Let's see. Mop ta bhijiye din. And you check the staple line with that tri-flange. Bhalo kore bhijiye ningre din. Now I will see what I can do about that thrombose piles. I'll probably do a little bit of laser there. I'll see.
Will you try to feel that staple line with your finger?
Pardon? No, we'll see the staple line visually. We'll see it.
Okay.
We'll see it now. Okay, so I'll take the gauze out. There will be a little ooze. See, the entire prolapse has gone. See that? Manoj? Hello?
Yes, sir.
See the picture I had shown you before the operation and now. So prolapse already gone. Okay? Now what you do is tri-flange. Now is to check the staple line individually. Hello?
Yes, sir. We are with you. Battery is come हो गया था, sir.
नहीं देखिए a prolapse completely gone.
Yes, completely gone. All the thrombose pile, external hemorrhoid, all has gone.
लेकिन ना वो तो gone नहीं, thrombose pile से थोड़ा रहेगा, उसको क्या करना है देखना पड़ेगा. Let's check the staple line first.
Yes.
So very adequate jelly. Okay? Very adequate jelly. And gently go in. Kichu korish na. Gently go in. Okay?
Okay.
Half gauge. Bheja. Non-tooth forceps. ভালো করে ভিজিয়ে দিন। ভালো করে ভেজানো আছে তো? দিন না। ভয় পাচ্ছেন কেন? দিন। ছেড়ে দিন। See? It's a little difficult to see, but
you can see and
that's the staple line. Staple line you can see.
On that side we will see.
Hey, देखो, भाई देखा भाई.
On the
see the staple line.
See, sir.
Yeah. Okay.
Sandeep da.
एक second, and that is 1 centimeter above the dented line. See? Yes. That's 1 centimeter above the dented line. Okay. Now, second half. Okay. See the staple line.
Sandeep,
see the staple line.
We are not able to visualize the staple line.
I know it is difficult. I mean, kya kare?
In the fourth.
No, can the camera person be on your right shoulder?
Okay, that's the staple line. It's decent, I can assure.
And what is the status of the thrombose piles there? In the
I'll check.
Because
so
it is in the same.
let me check the thrombose piles first. Sorry, the staple line first. No staple line bleeding so far. See the staple line here? That's the staple line. Okay.
Now the external component by and large.
Now I think you can see.
Sir,
No, we
please,
can't. Your head is in
your
between.
head is coming on the way.
Hang on.
Now we can see the staple line.
Yeah.
Yes.
See, it is 1 centimeter above the dented line.
Yes, correct.
Okay.
Yes.
That is very important. That is why your pulse string bite has to be at least 2 centimeter, if not a little more. Okay. Now what I'll do a completion proctoscope, because by stretching, you will not be able to see the residual piles. I am a little concerned about the one I saw at 5 o'clock and the one I saw at 9 o'clock with a little thrombosis. Okay. We'll now just have a look with the proctoscope. But this is my special proctoscope. It is quite wide, matlab chauda hai, and there is a light source inside. Yes. So I can, if there is a problem, I can always attach a laparoscopic light source and see. That gives a much better view. It will fit.
You have you have made it?
No, bhai, kharida hai conference se. That is why you go to conferences, na. You visit all the stalls and you will find instruments which are brilliant. I'll show you one more. Non-tooth forceps gauge. Non-tooth forceps gauge.
Now we have a good vision. Yes. Little bit focus required. Yes.
I am coming out. I'm coming at abjal nahi anyway. I'm coming out. So that's the beginning of that. That's my staple line below.
No,
it's visible. Above. That's our staple line. Going. That's our staple line. No bleeding. Pretty good. So staple line gone. Now I will look for the residual piles. That's the staple line. Can you see? Little bit you will see. Not entire of it. It's not possible.
Can you just shift the proctoscope to your left?
Okay.
Probably then or to the left. Yes.
That's the staple line. Yeah, that's the staple line. That's the staple line. Okay. Now I'm coming out. Very residual piles left actually. Very residual piles left. Okay.
Don't
only
you think that will be tackled?
The 9 o'clock I am little keen on. That's a little bit. 9 o'clock I'll put a little laser. Okay. And Meryl is standing on my neck, so I'll put a little laser on that.
Or you can take a bite, catgut bite, and
yeah, you can. No, I mean I'll tell you the options for residual piles, if any. One is plain simple phenol or polydocanol injection. Okay. The other is take a figure of 8 bite with 30 vicryl.
Okay.
Right. And the third thing is obviously laser.
But there are a lot of patients who present with pain if you take a stitch.
I know, because the stitch, as you say, you are absolutely right, Hiremat. The stitch is at the level of anodum, and that is painful.
Okay.
You are right. You are right. You are absolutely spot on.
No, that 9 o'clock, does it require anything to be done, or the staple line will eventually thrombose and it will settle down?
I'll show you. Ramdhar. I'll show you. A little laser will not cause any harm.
Yeah, exactly.
I'll show you.
Yeah, that we agree with you, yes.
এটা দাও ওটা দাঁড়া না ল্যাডিসটা দিন ওটা নিয়ে মারামারি পড়বে আপনার একজন গ্লাভস পরুন না ভাই মেরিলের আপনার ওকে অর্ডার দিচ্ছেন কেন
What about post-operative pain if you use laser?
Very minimal actually. I mean it will be the same, Alice. It will be the same post-operative pain relief you would have given for a normal staple hemorrhoidectomy. A simple paracetamol will do. I'll show it. Now can you see there is a little hemorrhoid here?
Yes, very well.
So
7
I think
o'clock,
that
9 o'clock position, is it?
It's
7
to 9, yeah.
Okay.
That I will do a little laser, okay?
No, this what you're holding, that's the external component.
Yes.
Won't that be tackled with your stapled hemorrhoidopexy because you were cutting and then stapling?
I am sure, Dr. Hiremat. I mean, once we come back to this patient after 2 months, I think everything will be flat. But I mean, for the sake of showing laser once again to the interested delegates, I'll just do this.
Sure.
Okay. I completely agree with you. On another day, I would have left it alone.
Okay, got that.
And told the patient that fine, after 2 months, if there is something residue, I'll do a little laser.
Okay. Okay.
I fully agree with you.
Got it.
চলো লাগাও তাড়াতাড়ি লাগাও ভাই না এটা তো নয় আচ্ছা somebody asked me here why not an FG hall here because we have already done the FG hall. Yes. It is a circumferential FG hall. Yeah. কি করছেন ভাই তাড়াতাড়ি করুন আপনারা রেডি করে রেখে দেন না কেন আপনি তো আগে তো রেডি করে রাখা উচিত পুরো জিনিসটা ফাইবার করে
What is the laser setting?
Okay, I think I'll go a little low here. So I will do 7 watt for grade 1 hemorrhoid, 7 watt. Joule I will be using maximum up to 100. Okay. Machine does everything. I'll show the machine. Machine ta dekhao. So they say piles. No, see, they say piles. They say fistula. They say fissure. Varicose vein, pilonidal sinus, okay? So you press that button. Then piles mein aa jayega grade 1, grade 2, grade 3, grade 4, okay? So you press that, automatically it will come. Then whether you want to increase it or decrease is your under your purview. Dekhao baba. See? Dekhacho machine ta. So you press piles, wait, see anal fistula, hemorrhoids grade 1, hemorrhoids grade 2, hemorrhoids grade 3, hemorrhoids grade 4. Fistula, abar ki? Fissure, pilonidal sinus. Chalo, grade 1 e dao. So it's 7 watt karo.
Oh, so these are the set standards for that.
All the machines. Acha, this is again a 1470. Yeah, this is a 1470 wavelength. Okay, light off, please.
So Sandeep da.
Yes.
At Ramaya Medical College, Bangalore.
Right. Hey, Aman, hey, pedal dao. Pedal kotha hai? Yeah. Dr. Hiremat, yes.
So I'll call you for a demonstration there.
Oh, no, bhai, suno. As I said, again, I can't say that publicly. I mean, this is an operation. I am not an expert, boss, okay? I mean, I'm not an expert, but I think, as I said, every surgeon should learn it as an additional tool. Ready?
Exactly correct. So, what is wrong in coming and accepting the invitation?
Yeah, I love to go to that center of excellence because we all know Ramaya, even being a private medical college, is probably one of the best in our country and matches any government hospital.
Yes, exactly.
So entry is like this.
You are going inside the pile?
Yes. I've gone in.
And how long you stay there?
Not long. How much you want to buzz? Koto hoyeche baba? Are koto dilam bolbe to? Cut. Time kothay? Joule koto holo? Ke machine er lok acho? Oh my God.
You take out better.
কি বলছো 2070? মাথাটা খারাপ হয়েছে নাকি তোমাদের? Okay, I come out. Machine চালাতে জানো না?
And there is another pile below.
বরফ নিয়েছো? আইস নিয়ে একটু. We'll take a little ice. কে মেশিন চালাচ্ছে এখানে? তো জিজ্ঞেস করছো তুমি বল তোমার তো কাজ হচ্ছে বলা যে কত যাচ্ছে মাথা নাচ্ছ কি 75 গেছে বলতে হবে না আমি বললাম যে 100 বেশি যাব না তোমার তো বলতে হবে যে স্যার এতটা গেছে একটু বরফ দে মা
So you need to put a ice?
Yeah, it's not there, they're bringing it.
So is it mandatory for after every laser?
Yes, it's mandatory. They've kept it. I'll just have it. তো নিয়ে রাখবি তো বরফটা জানো যখন লেজার করবো তো নিয়ে রাখবে এই ছোট ছোট ভেঙে দাও অত যাবে না for about 30 seconds ये क्या है ना, मतलब आग जलाने का बाद थोड़ा ठंडा करने को लिए.
Very true.
ना लगेगा.
To direct eyes, not in God piece or something.
Direct.
Sandeep da.
हाँ.
What are the other cases, if any, today?
I think if Rajesh is finishing his, Omda finishing his, we are finished.
He has finished both
Dr. Hiremat.
Yes, sir.
Everybody could see it properly, na?
Yes,
Very well.
Okay, thank you.
Your demonstration is spot on, superb.
Yeah, superb.
Thank you, sir. Thank you.
And your
adequate
audio
commentary.
visual.
Okay, sakat. Okay, so I think eyes application is done. So we gently come out and then we just do a check proctoscopy once again. And I can actually show you that there will be a certain proctoscope. There will be a certain collapse of that spice. Bhai kichu mona koro na, jholale kintu, ha? Not expected. No. Our half gauge are. No. It is down. Okay. Lomba kore bhanch koro ota.
Sandeep da.
Okay. Yes.
There is
Just
a question,
finishing.
There is a question from the delegate.
Please.
In stapled hemorrhoidopexy, while you are taking a purse string,
okay,
standard of teaching is you take between the submucosal plane, isn't it? Circumferentially.
Deep to submucosa, but not up to muscularis propria. Yeah.
So how will you, if you have taken a deep stage and
right,
you have involved the muscle, how will you know that you have taken a muscular component in the purse string?
I'll just show you one thing. See the collapse. See the collapse.
No, we can't see it now. We are not having a good video.
Okay.
Audio is good.
No, I can assure you that the area where I put the laser has instantly gone down.
Okay.
Significant reduction. Okay.
No. Did you get the question from the delegate?
Yeah, I'll tell you. It is certainly practice. Okay.
Okay.
Now, accidentally, if you take a bite in the muscularis propria, okay, it's not going to harm that much.
Okay.
It is not going to harm that much. As long as you are not taking the serosa as well, right? Okay. I mean, essentially, it will be anastomose with the staplers.
Correct.
Right. So it will not add to anything else because the arteriovenous anastomose is at the level of the submucosa. So an accidental muscular bite is not going to cause a big harm. I think we all have done that, to be very frank, during our initial days.
No, initial days we might have done it unintentionally.
Yeah.
And as you are told, the donut has to be sent for histopathology.
Right.
So is there going to be any consequence of the muscular fibers being there any time to the patient? That is the question.
No, I don't think so.
Okay.
Not really. The only thing is when you take the needle out, if you see the blanching, that ensures that you're in the right plane.
That's correct. Fine. No, if the question is regarding muscle fibers being in the
donut.
In the donut, correct.
Okay, and the patient comes and asks you, sir, there is muscle here in the biopsy.
तो क्या हो रहा है, ये क्या है, इससे कोई मुझे तकलीफ होगा क्या करके?
No, I think you have to be smart and say, see, I mean, at some places the muscle can come in. This is not going to cause any harm to you functionally, structurally, etc.
Got it.
Okay. Now, if you carefully show, because I'll be coming out now.
No. Can you just tilt your scope to your left?
Yeah.
No, your handle to the left.
Okay.
Yes.
Now follow the 7 to 9 o'clock area. No, you had seen that before?
No.
Now you see it now. You see it now. It's not there. It's gone.
Okay.
It's gone. Happy?
Happy.
Abjel দুটো লম্বা করে।
So
জেলি লাগিয়ে।
Dual technique.
আরে না, ওইটা লম্বা করে কাটুন। এই তুই তো আগে থেকে দেখলি।
Dual technique.
আরে লম্বা করে কাটো। I'll just show you. I hold it here at the level of the staple line. Then take a spongystone or abgel or spongylus. বাবা অত নয়। আরে দুটোকে ধরুন আগে। আগের কাছে তুই দেখলি তো বাবা, এরকম মোটা করে দাও।
Some people, Sandeep, are habituated to keeping gauze piece with little bit of tincture benzoin.
No, I tell you what.
How about that?
I just do this. I have taken, you can see.
Yes, I can see very well. You can
I've
see.
taken a spongy stone,
Yes.
longitudinally cut into half,
Yes.
put it like a pack, half in, half out. That's it. So it ensures that it is in the staple line.
Got it. That's
Okay.
fine.
That's the dressing.
Alternatively, can we use tincture benzoin with gauze piece?
No, gauze is a big no, no, no. I tell you why. You have staples. You have staples.
Or you
So-
can yank it, is it?
No, I mean the staple can get stuck in the gauze, and when you take the gauze out, few staples might come out.
Okay, okay.
It's a risky venture.
Yet another question.
Yes.
Patients ask us, Dr. Saab, how many staples have you
Ointment.
used?
Pardon?
Patients many times ask,
Huh?
the staples you have used,
Huh?
will it fall off?
Yes, they will fall off over a period of time. And they will say, will I see it? You tell them that you sometimes might find it in your stool, don't get panicked. But most of the time they don't actually see.
Okay.
I mean, to be very frank, Dr. Hiremat, I have been doing it since 2001. It's not that I do a lot because of the cost reason. Okay. And after I've started doing FGHAL and injection sclerotherapy or laser, I mean, stapler has come down. But stapler is fantastic for circumferential piles.
Second degree, third degree
Yeah,
circumferential.
you are asking me a question there that if you have large piles and also secondary piles, I think in that case you will always be doing a stapler hemorrhoidectomy rather than laser. Where you have circumferential. The only dressing is you take T-Bact or betadine ointment and the 4 needle holes you apply little bit, okay? Then a dry gauze and a little micropore. That's dressing. No T-bandage, nothing. This patient does not require any seeds bath because there is no external wound.
Okay.
And catheter for first 24 hours.
Few of the patients also ask, how many staples have you used?
ये तो मुझे भी मना, I don't know. I mean,
There are 31 titanium staples.
right, okay. I didn't know that, boss. Now, you are a professor, you know better than me. I am not in teaching, so I mean, मैं तो ज्ञानहीन आदमी हूँ.
You are a doyen boss.
Okay, so this is simple dressing. Anything else technical I can answer? Well, I didn't know 31 staples. I know 2 layers, na? Two rows.
Yes, correct.
2 rows, 31. Okay, I'll remember that for the rest of my life.
Sir, there's another question from the audience.
Yes, yes.
Your experience vis-a-vis MIPH versus Chivate's procedure.
Right, okay. Now, to be very frank,
Yes.
I admire the transanal suture rectopexy.
Alright.
That is Chivate sir's invention or technique. Okay.
Yes, yes.
I actually personally haven't done that. I can do it because it's based on the principle of FGHAL.
Correct.
Okay, it's basically like that.
Circumferentially, it ligates whatever vessels comes in that area, isn't it?
Absolutely, and it's interlocking so that there is no constriction. So
exactly
interlocking, and in 2 layers, 2 centimeter proximal to dentate line and 3 centimeter proximal to dentate line.
Correct.
So
correct.
That takes care. I mean, the only disadvantage of this, I think, is, I mean, he claimed, late Dr. Shivate claimed that corrects piles, but I don't think that corrects the prolapse. That doesn't correct the prolapse.
It doesn't
That's
correct
subtle.
prolapse, correct, but it takes care of the second, third degree hemorrhoids, isn't it?
Absolutely. That is a poor man's staple hemorrhoidectomy, boss.
Got that. Punchline, poor man's stapler hemorrhoidectomy.
But it's not very easy to perform. Okay, taking bites, interlocking, and the second layer is not going to be easy. It's not that easy. It looks easy if he does it. If Dr. Shivate does it, or Dr. Kushal Mittal does it, or Dr. Niranjan Agarwal does it, I mean, it will probably look very simple, but it's not that simple. I mean, taking staple bite here even is not very simple.
I know.
It's very cumbersome. Exactly. But this is a good technique. Apart from the cost, I have repeatedly over the years told the companies, please cut the cost down. piles is a common man problem, okay? And it's predominant in the lower middle class and poor population, okay? They can't afford a stapler for 20,000.
For our residents, the punchline standard is you must know 3H: hernia, hemorrhoids, and hydrocele.
Absolutely, absolutely, absolutely. The 3 open operations everybody should master before they master a lap chole.
Exactly, correct.
Because if you are posted in a primary health center, okay, which many of us will have to do at the beginning of their career, they have to do a hernia under spinal or even local, a piles under spinal or even pudendal block, and hydrocele under local, spinal or local. So you are absolutely right, Dr. Hiremar.
Sandeep, when you started your MIPH in 2001,
yes,
what was the price of the MIPH? That time, obviously, yes, as you know very well, it was Johnson & Johnson.
I know it was Johnson & Johnson.
Standard 31 size.
Absolutely. In 2002, when I first did it in Kolkata, the print price was 12,500.
Okay.
And now in 2024, after thousands and thousands of these instruments are used, the print price is probably Johnson & Johnson will be 23,000, 24,000. So this should actually, the reverse should be there. Na? See, basic laparoscopic instruments. I'm not talking about the 4K, which I use in 40s, 65 lakhs, okay? I mean, spyglass, 1 crore. I'm not talking about those.
Okay.
Basic laparoscopy, what was costing 7 lakhs, 8 lakhs in 2001, you will get 3 lakhs, 4 lakhs. Okay, so mango surgeon, arm surgeon, okay, will be able to buy it.
Correct.
I mean, if somebody is starting a practice in a rural area in a small nursing home, and how can he afford 20 lakhs, 25 lakhs for the hardware?
Another question. Now, there are many variations of MIPH only, where there, as you know, since it got popular, lot of other pharma companies have come up with the similar technology, right? You have seen Lotus and many. Have you seen any difference in your personal experience? Any difference between the Johnson & Johnson and the one which is produced or manufactured by Lotus? Or many of them?
No, frankly speaking, Merrill came second. I mean, they copied, I mean, exactly copied the Johnson one, and I used Merrill quite a few times. I've used it. It's called Miras, okay?
Okay.
There is no difference. Only the quality, the plastic quality, okay?
Exactly, correct. Yes.
When you hold a Johnson, you know these are Johnson, okay?
When you're blindfolded, you know you're holding Johnson and you know you're holding not Johnson, right?
Absolutely. But as far as staple line firing and other things are concerned,
there's no change.
I have not found any difference. Covidian I used, but I found using the anvil separately and then attaching and then closing and then taking out was a bit cumbersome. Exactly. So I am a very strong patron of Medtronic in mesh and other things, they know. But I mean, about stapler, I said, look, I mean, this detachable anvil is a bit cumbersome with this procedure.
Exactly. Any difference between 31 and 33? Even in Johnson, even when you ask in the theatre, at least in Ramaya Medical College, Bangalore,
right.
They ask me, sir, you want 33 or 31?
Right. I think if it is a young patient with a narrow pelvis, okay, I will be 31. And if it is a lax, big patient, okay, lax pelvis, right? 33. I mean, patulous anus, 34. Yeah, I use 34 here, 34. Yeah, 33 or 34. Yeah.
Okay, got that. Fine.
Okay.
Thank you very much.
Thank you all. It was a very, very fruitful discussion. Really enjoyed the discussion part because you are so well read and you are all teachers in different renowned medical colleges, yourself and Manoj from AIMS Patna. So it was really, I mean, I have a very...
but you are the Dada.
Yeah.
But Sandeep,
I feel honored to have participated in such discussion. Thank you.
Sandeep, thank you very much. Thank you.
Thank you. এই লেজারের লোকটা কোথায় গেল?
technology is not a more short.